is exactly 4 p.m. Okay. Good afternoon, everyone. Today is August
Recording
27th,
in progress.
2025, and it is 4 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference. I see Chair Kitchen online and Manager Rodriguez. So we will be monitoring all feeds and of the participants closely to make sure we have a legally compliant meeting at all times. At this time, we are going to be taking public communication, and I would like to announce that in order to make it more accessible to the community, well, actually, we're going to take all public communication at this time, unless there's someone who comes later, and we will grant their time as well. So, Yesenia, could you please?
Yes, I will now read off this evening's public communication guidelines. When
Thank
called
you.
upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. At 4 p.m. today, we have 12 people signed up for public communication. I will take the 4 that are virtual first, and then we'll move on to everyone that's here in person. At this time, I would like, let me see, Thomas Rosen from Rosen's Bagel Co. and Good Work Austin to please unmute.
Hi, how are you? Can everyone hear me?
Yes, we can. Please proceed.
Okay, sorry. My name is Tom Rosen. I'm a member of Good Work Austin, a coalition of restaurant owners who are supporting various measures to make, sorry about that, to support various measures to support the hospitality industry in Austin and create better conditions for hospitality workers. And I am the co-founder and owner of Rosen's Bagel Company. And I come today not only as a business owner, but as someone who has been personally and deeply affected by the healthcare crisis facing Austin's hospitality workers. And I wanted to first thank you all on the work that Central Health has done for general healthcare in Austin, and then also begin to ask and see if there's anything more that we can do for the hospitality workers uh, in in the greater Austin community. And part of the reason why this is such a big deal to me is that 2 years ago, my business partner and coworker, someone who I spend most of my days with, was diagnosed with stage 4 colon cancer. At the time of his diagnosis, he was our general manager, and just as he had been through his 12 years in the Austin hospitality industry, he was uninsured. Navigating his treatment has been heartbreaking, not only because of the severity of his illness, but because of the lack of healthcare options available to him as a hospitality worker in Austin. This experience has left me shaken, both as a friend and an employer, and it has underscored just how vulnerable our workforce truly is. And the reality is stark. Travis County's 65,000 plus food workers power a $9.6 billion hospitality economy and make Austin a culinary destination, yet there are few options available for them for healthcare. And as an employer, we want to offer supplemental support for our teams and whatever we can do, but the options in Austin are simply scant. It's why I'm urging Central Health today to prioritize affordable, comprehensive healthcare for food workers and the creation of some sort of innovative pilot programs to target the hospitality industry, similar to what has been done for Austin musicians. A sick workforce can't sustain a healthy hospitality industry, and I hope that you all will consider investing in food workers' health and consider that you are also investing in Austin's economy, culture, and future. And thank you so much for your time and
Thank
all
you.
you do for the area.
Thank you. Appreciate it.
Thank you, Tom. Up next, we have Asia Ashley. If you can please unmute.
Hi, my name is Asia, and I'm a proud employee of Integral Care. Thank you to the board for the opportunity to speak tonight. Integral Care is the safety net for thousands of people in Austin, the only accessible option for mental health care for many. We provide crisis support, life skills training, housing services, and more. And all of that is made possible by our frontline staff. These are the peer support specialists, medical assistants, and case managers, the people who answer the phone when someone is in crisis, who greets clients at the door, and who walk alongside individuals during some of the hardest moments of their lives. They are the foundation of our services, and without staff, we do not have services. Right now, some of these essential workers are making as little as $20.83 an hour, while the MIT calculated living wage in Austin is $24.42. That difference may seem small on paper, but in real life, it can mean losing stable housing, being unable to afford childcare, or not having reliable transportation to get to work. These low wages contribute to high turnover and chronic vacancies. This results in clients experiencing longer wait times, missed appointments, and some going without care altogether. And for the staff who remain, it means greater burnout and often more resignations. Recently, all employees received a 4% raise. While appreciated, this across the board increase disproportionately benefits higher paid employees. Additionally, there have been significant raises for executive and upper management throughout the year. This approach is not equitable. Frontline workers, those doing the most demanding indirect work, remain in the lowest paid brackets. Without addressing this imbalance, we risk further destabilizing our workforce. Raising wages for these staff is not just the right thing to do, it is a strategic investment. It improves retention, strengthens our ability to serve clients, and makes Integral Care a more attractive partner for funders seeking sustainable, effective organizations. Especially now, as federal grant funding becomes less reliable, we need to demonstrate stability and resilience. So I respectfully ask you to please dedicate additional funding to raising wages for the lowest paid frontline workers at Integral Care. This isn't just about salaries, it's about sustaining care for our community, honoring the people who provide it, and strengthening the safety net so many Austinites rely on. Thank you for your time and your ongoing commitment to the health and well-being of this community.
Thank you, Asia.
Thank you, Asia. Up next, we have Aswini Sivaswamy.
Thank you. Thank you for having me today. My name is Aswini Sivaswamy. I'm the founder of Cessapure. We're a wellness-driven beverage company here in Austin that started about 20 years ago. So we've been around for a few decades, and we've been on this search for healthy pathways that started on a personal mission. And over time, we have been servicing our local food and beverage industry. So as a member of Good Work Austin and as a member of a small business, continuing to not only just thrive, but sustain in the city, we are thankful for having the opportunity to work with fellow members of Good Work Austin and other businesses that actually care about their employees. So I'm here today to present an opportunity to Central Health, but also it's more than an opportunity, it's a critical need to provide your vital services to a community that's so integral to this culture of our city, that's growing in number of workers servicing the Austin food and beverage industry. That's not just helping the industry, but it's helping our entire community and the city's economy. Good Work Austin, as Tom mentioned, is a coalition of a growing number of businesses that have been working together from the beginning for over about 7 years now, that are actually day-to-day working firsthand with the challenges of these essential workforce. We have seen the number of businesses that are continuing to close, and or people that are moving out of the city, and that's a part of also the culture that's being driven away, that actually has been growing the continuous growth into this community. So many of our individuals that are working in our industry work multiple jobs with inconsistent income, and most of them in the food and beverage industry are among the lowest paid positions in our city, well below the $24 an hour pay wage that was just mentioned in healthcare and or other industries. They're often leading them to not be well physically and mentally, emotionally, and yet we're supposed to be there day in and day out throughout the year. The food industry does not close. We are open 24/7 throughout the year and even on the holidays to service our community. Yet we do not have the access to traditional healthcare to just keep us going and not only be well, but also just function healthily. So this is a very close to home situation because that's how the foundation of CESA started. It was about finding a path to wellness. And most of our team members throughout the years continue to have other ways of creating income and other ways of searching for health services in order to maintain and be a part of this community, if not leave. Affordable healthcare is unfortunately not even accessible to some of our businesses. And as employers, having to bear that weight is already a challenge.
30
So
seconds.
working with other organizations and other businesses and collaborating with organizations like Good Work Austin and Central Health is not only a invitation to do something better for our city, but it's investing in the health and well-being of our industry and the community at large. And it is a need for our essential workers. Thank you for your time and consideration. And we hope that you can use each of our businesses, each of our stories, as well as Good Work Austin as a resource to do better things in our community for each other.
Thank you.
Thank you, Aswini. Up next, we have Kelsey Creek.
Okay, I think I'm on. Am I live? I feel like I'm live.
You are live.
All right. Hi, everybody. Thank you so much for being here today. My name is Kelsey Creek, and I'm a local singer-songwriter and musician out here in Austin. I'm originally born and raised in Louisiana, but I've been out here calling Austin my home for the last 6 years or so. I will also address the elephant in the room. I'm currently growing out my hair, so I look like Manny the Mammoth from Ice Age. I apologize. But to talk about what Central Health does for HAM members out here in Austin, I feel like there's not enough time or words, I think, to really describe like the gratitude that a lot of us musicians feel for having health care and access to health insurance. I spent a large portion of my adult life without access to health care. And even though some might say I was in my prime, my health was not. And I definitely suffered a lot with my mental health, my physical health. And last year I was in a high-speed car accident that left me physically in pain. Financially, I was struggling to survive, and Central Health was there to help me go to doctor's appointments, was there to help pay for my ER bills and my medical bills, and to think about not having access to healthcare. I don't even think my brain can fathom the not only financial ruin, but the physical pain that I would be in every day if it weren't for that. And I think that what y'all are doing is obviously extremely important, and it's so greatly appreciated. And I wish that there was, more funding put into stuff like this, because I think, to echo what everybody else here is saying, is like, it really is not only life saving, but life changing to be able to have access to healthcare. And a lot of people just, struggle with being able to do their, just like day-to-day check-ins and appointments, and to be able to have that every day, to have access to healthcare is a huge, important thing that I know everybody in my music community really appreciates, and it strongly impacts our ability to do our job, everybody's job here that is speaking today. So I want to say again how appreciative I am for everything that Central Health does. I am forever in debt to y'all. Literally, like, my life has been saved through y'all, and so I greatly appreciate that. And I'll end it with the words from 3 aliens from Toy Story, which is I am eternally grateful for everything you do. So thank you
Well,
so much for your time. I hope y'all have a great day.
thank you, Kelsey. We're grateful for you as well, and I'm glad you're doing well. Thank you for talking before us. Next person.
Thanks, Kelsey. Up next, we have Kim Caldwell, and I think this is the last person online. So next up after Kim in person will be Sharon Alvis, if she's here.
She is.
She is? Okay, perfect. Kim, you can unmute. You have 3 minutes. Thank you.
Thanks so much, Yesenia, and thank you all. Thank you, board members, and all the leaders I see here, and I can see some tiny folks in the big room. I am so proud, Kim Caldwell, so proud to be the board chair of Good Work Austin. And as you've heard from restaurant owners and the representatives we've had speak already, don't worry, there are more. We really are here to help the service industry be good and do good. I got to know Good Work Austin first during the pandemic when I was part of the folks at the City of Austin tasked with closing the food gaps for people experiencing homelessness. And when Good Work Austin was able to come to the table and be that force for restaurants to not only keep that money in our local economy, but keep food service workers working and earning wages. I knew this was an organization that I needed to be part of. And now as board chair, I am so proud of the work that we're doing to continue to look out for the folks who take care of us, right? Food is more than fuel. Food is culture. And food is so much of our economy, right? What's somebody going to do while they're listening to Kelsey? They're going to eat, they're going to drink, and right, that food has come from somewhere. It has been prepared by someone. And what we also learned, right, this decade so far, is that our health is interconnected. And so a healthy food service workforce is absolutely necessary if we are going to have a healthy community. And y'all understand the complexities of healthcare, and y'all know a lot about the systems here in Central Texas that exist and the ones that don't exist to care for folks who make our community what it is. I'm not gonna make anyone raise hands, but I'm guessing all of us on this call, if not in the last 24 hours, in the last 48 hours, have received service from someone working in the food service industry. And like Good Work Austin advocated for paid sick leave when the organization first started, before I got involved, we continue to show up because having a healthy workforce matters. We have to find ways to make it possible for people to be part of our food service industry and take care of themselves, their families, right? Their neighbors, their pets. And I know y'all aren't, I know y'all strictly serve humans, but you know, it's easier to help the furs when we, as humans, are healthy. So please, we are so excited and hopeful that together we can innovate ways to have Austin's food service workforce and our community be as healthy as possible. Thank you so much.
Thank you, Kim, so much. Appreciate it. I would encourage everyone to stay online to hear Ms. Sharon because she has an important announcement for the community to know and learn about. So welcome.
Thank you very much, and thank you to the Central Health Board for hearing me out on this. We just wanted to come forward and
Can you
share.
introduce yourself?
I'm sorry, I'm Sharon Alvis, and I'm the CEO of Sendero, and I'm also associated with, as an executive vice president with Central Health. So I just wanted to share some of the anticipated changes that are coming forward in the ACA. The One Big Beautiful Bill Act has introduced several provisions that significantly reduce access to the ACA marketplace. And I just kind of wanted to educate people on some of those. There is an elimination of the automatic re-enrollment for individuals receiving premium tax credits. It used to be if you were set up and you're receiving them 1 year, you were automatically re-enrolled. That re-enrollment has been eliminated. It eliminates provisional eligibility for premium tax credits while applicants are waiting for the eligibility determination. So it used to be if you applied and you were in the waiting period while they determined, you still had access and you still had the premiums. Now those individuals will have to pay the full premium until their eligibility comes through, which might be a month or 2 months or 3 months. They will have to pay the full premium without the premium tax credits. It also ends the monthly low-income special enrollment period. We used to be able to identify individuals who might have urgent healthcare needs and did not have coverage, and given a certain income level, we could automatically enroll them based on their income into the plan at any time during the year, not having to wait for open enrollment, and that has also been eliminated. It imposes new administrative burdens on enrollees by adding additional income verification processes. So for individuals with the incomes between 100 and 400% of the federal poverty level, they will now have to basically re-enroll and verify their income all over again, which could again lead to them having to pay the premiums if it hasn't been processed timely. It also removes the cap on the amount of tax credits that enrollees must repay to the government if their income changes during the year. So if someone assumes that they apply for the income tax credits and their income exceeds what level they fell into, and when they file their taxes the following year, they will then be responsible for the full impact of that. There used to be caps on those based on income level. Those caps have been removed, and now the full repayment will be due back to the federal government for anyone if they underestimated their tax implications. So, and also, of course, we know that the enhanced premium tax credits are expected to expire at the end of 2025. So that the Congress could still act again and extend those, but we're not holding our breath. So what Sendero is trying to do in this process is we think it's such a challenge for people to understand the changes that are going to play out in the ACA that we're undertaking a pretty extensive marketing effort based exclusively on education to help the public understand how this plays out because it's so significant, and we think it's going to be a significant impact on people being able to make choices in that process. And to further confuse the process, on Friday of this past week, there was a judge I think in Baltimore, if I'm not mistaken, who put an injunction against some of these components. So it's made it even further up in the air as to how it'll actually ultimately play out. And of course, it's so close to the start date, we don't know whether they'll appeal the injunction of the federal judge, but stay tuned. That's all I can tell you, because we're going to do everything we can to educate our population and the community at large on the challenges that we're seeing with that. So thank you very much for hearing me out.
Thank you so much. Is this information also broadcasted on radio, TV? Like, I just wanted to know, because the community at large need to know about these changes.
That's what Sendero is going to take on.
Okay, thank you.
We're going to try and do just that to help people understand.
Can you wait till the item comes?
I just had one quick question. In my,
One
that's
second.
fine.
Lawyers, I'm sorry, it's need to
Yeah.
ask.
Okay.
Can we can address it during the Sendero item. Thank you.
Thank you very much.
Thank you. Up next, we have Zachary Jebsen. Zachary, are you online? I'm not seeing Zachary. If not, then we have Jeff Jackson, who's here in person.
Come on. If you can turn on the microphone. It just wants to turn. Yeah, there you go.
Hello, can you hear me?
Yes.
Okay, yeah. Hi, thanks for opening this forum to the public. I really appreciate the opportunity to be in front of all of you today. My name is Jeff Jackson. I'm the owner and operator of the Green Cart. We supply breakfast tacos to a bunch of coffee shops here in town. We feed about 1,300 people a day with about 18 people. And I'm also part of Good Work Austin. So there was like 4 or 5 people digitally that were just talking about that. There's a few more people in the crowd. We are a group of restaurant owners and food service company owners that have come together to advocate for food service workers. So that's whenever you hear somebody say I'm here with Good Work Austin, that's what they're talking about. There's about 70 of us. We pay to be in the group. It's a nonprofit, and we pay dues just to be in and help participate and move some of their agenda forward. I'm here because my company's #1 value is that we take care of each other. And I think that aligns well with what Central Health does for trying to get healthcare access to the people that need it most. What I'm here to request and to support for the Good Work Austin's general request is that you guys find space in your budget to pilot some kind of program for figuring out healthcare access for food service workers. We're not asking that you solve the problem right now. We're asking for a small pilot program. So we're talking about like less than 1%, a fraction of a percent of your total budget for this. And then meanwhile, if we can just figure out what it takes to start to structure something that could work. I know there's a lot of headwinds right now. I know that the political climate is not great to be trying to do this. But if we could do a small program just as like a tiny spark off of your budget, there's 70 business owners that are interested and active and want to see something happen here. So there's ways, we'll be working to figure out other channels to run with that. If you guys could just do the small act of figuring out just what it would take and what that sort of administrative structure could look like. Probably something similar to what HAM is doing, but maybe not. But just some small, less than 1% of budget for supporting what is effectively in Austin, the working poor. The 65,000 food service workers here are among the lowest paid cohort in the economy. So that's who we're talking about, and that's who I'm personally here to advocate for, along with my colleagues in Good Work Austin. Thank you.
Thank you so much.
Thank you, Jeff. Up next, we have Ben Fordham. Thank you, Ben. You have 3 minutes.
Hello, everybody. Thank you for giving me the time to speak to you today. My name is Ben Fordham. I am a restaurant operator here in town and also another member of Good Work Austin. And I've been here, you may have guessed, not all my life. I came here about 7 years ago. And in that time, I've operated, led about 15 restaurants across Austin, from high-end Michelin-starred fine dining down to fast food restaurants. And one of the drivers for us coming here was the dynamic place that Austin is, its growth, and alongside that goes with its amazing food scene, its amazing hospitality reputation, and that is growing and at pace with the population growth. But one of if there is a constant among all of those different varieties of business for the employees, that constant is trying to get a livable wage, trying to be sustainable in this city where costs are going up. And if there is one constant on the operator side, it is how to maintain a sustainable business with all of those financial headwinds that it has. And to find a way that those two align is a very difficult thing in this business. And yet, as has been said before, it is a huge business. 65,000 people working in it. 9.6 billion, I think, is the number that it brings into the economy. And so to have all of those people and to have all of that revenue, and yet to have it as so unstable as it is, with most of these people not able to afford the sort of healthcare that they need for regular checkups, to maintain their health means that those people are either coming into work not healthy or not able to come to their shifts and make their hourly wage. So has been said, the reason that we're here, that I'm here, is to ask to try and find a way that if there is that this board and Central Health can find their way to seeing some sort of affordable care option, some sort of program, again similar to what HAM has, whereby we as a group can try and drive this forward, because it is fundamentally important to us as business owners, as restaurant owners, but as people who work in this industry and work in this city and are desperate to see it thrive and to continue to attract people, both visitors and to live, which it undoubtedly does as part of the fabric of this city. So yes, I think that's everything. Thank you very much.
Thank you.
Thank you, Ben. Up next, we have Chelsea Elliott. And after Chelsea will be Rachel Blair.
Hi, good afternoon. My name is Chelsea Elliott. I'm the founder and executive director of Half Helen and the Half Helen Eye Clinic. And I want to begin with a thank you heartfelt to Central Health and to Community Care for recognizing the importance of vision care. My journey in vision health began with a failed screening. At 4 years old, I learned that I was blind in one eye, and in kindergarten, a failed hearing screening revealed I was deaf in one ear. When I learned about Helen Keller's life, I boldly declared that I am half blind and half deaf like Half Helen. And I never dreamed that my childhood nickname would come to characterize my work. For the past 12 years, Half Helen has helped Central Texas children, families, and seniors see the world clearly. In 2021, we expanded to serve MAP and MAP Basic members, including Sendero members, through the Community Care Vision Voucher Program funded by the St. David's Foundation. The expansion moved us beyond serving children in schools and to serving adults and seniors in the community who needed access. That entailed learning about diabetic retinopathy, glaucoma, and macular degeneration, which are vision issues affecting MAP and MAP Basic and Sendero members today. In December 2023, with help from John Morgan and the Central Health Operations team, we joined the network as an optometry provider, providing medical eye care to your members. Days later, we opened our new optometry clinic at North Lamar and 183, and we've provided nearly 5,900 Central Health members with comprehensive eye exams, and of which 91% received prescription glasses with us. Behind every number is a story: a child who is able to see the board, an adult who's able to drive, a grandparent who's able to safely cook and no longer cut their hands because they can't see. Recently, a MAP 100 member came in for glasses. 2 months later, he returned to us because he had gotten a piece of wood stuck in his eye. He was on his way to the ER when he remembered Half Helen and came to our office instead. We saw him that day and we saved him a trip to the emergency room by helping him, and because we were a network partner. At Half Helen, we work every day to break down these barriers and make care accessible and affordable for MAP and MAP Basic members. We're excited to welcome John Morgan and Dr. Shalsha to our office next week to talk about how we can further align and continue serving your members and their vision care needs. Thank you.
Thank you so much, Chelsea. Appreciate it.
Thank you, Chelsea. Up next, we have Rachel Blair.
Hi, everybody. I'm Rachel Blair. I'm the Chief Strategy Officer at HAM. And the main thing that I wanted to express today is just heartfelt gratitude from all of HAM staff, our board, and the thousands of musicians that we've served together in our community. Want to thank y'all for your commitment to healthcare access and equity. And I think one of the things that we have done together is build a system that is both comprehensive and life-changing. So I want to thank all of y'all, and I want to thank the Central Health staff who've worked with us and Sendero staff who've worked with us over the last few months as we've been trying to tease apart all of the changes to the ACA. What that's going to mean for this rapidly approaching open enrollment cycle, and what it's going to mean for the people who depend on us for their health care. We have Ham and Central Health and Sendero partner together right now to cover about 1,400 folks over about just around 1,200 plans. So Ham members and their family members. Ham members have very low incomes and they do not have employer offer coverage because they are gig workers and small business owners. They're creative entrepreneurs, people just like Kelsey, who is a hoot, a wonderful human being, and just somebody who we adore immensely at Ham. So big thanks to Kelsey for coming today. Ham members use preventative services, specialty services, primary care, and specialty care, which is incredibly difficult to find, especially if you're otherwise unfunded. One of the things that we've worked with y'all on over the many years of our partnership is really advancing healthcare equity. We've been addressing disparities and expanding access. And one of the ways that we measure that is through the representation within our new members. So within this population of folks that we've engaged through community engagement, internal capacity building, and equity-centered programming, is that we've seen a 91% increase in racial and ethnic diversity among new members, a 48% increase in women and non-binary representation, and non-binary and gender diverse representation in our membership has gone up to about 8.5%. So we're really committed to the continuation of deepening relationships and expanding our equity focus in that centering of our work, and want to say thank you to Central Health for that partnership, in particular with the CHIF grant that we engaged with for a couple of years and ongoing premium assistance funding. So, and just in summary, I just want to say that I think, we've created an incredible connected system of care that includes comprehensive coverage and, really importantly, removes financial barriers to care, as many today have spoken to. We know among Ham members, cost is the number one barrier to care. We have created a model that proves that safety net institutions and nonprofits, when they align, we can do amazing things and we can bring our goals to reality. So we want to thank you for your leadership, your advocacy, and your trust in us to help deliver Central Health's mission and Ham's mission together. And we're proud to be your partner in keeping music alive and well in Austin, Texas. Thank you.
Thank you, Rachel. Appreciate it.
Thanks, Rachel. Up next, we have Lynn Cowles. And after Lynn will be Adam Orman.
Thanks, y'all. Oh, maybe not that close. My allergies are kicking, and my name is Lynn Cowles. And I work for a healthcare policy organization in the daytime, and I'm also a Good Work Austin board member. And I am here today to talk about a lot of the access to healthcare that you've heard some of my colleagues and coworkers talk about here today. And I think, well, I also want to echo Rachel and just start with a lot of gratitude. Central Health has done amazing things, offering premium assistance programs to people who would otherwise not be able to afford health insurance. The model that Central Health has created between Sendero and local funding resources and state funding resources is like really unique and innovative. And I mean, working in healthcare policy in Texas, there's not another system like this in the state, and only a couple other that I can think of around the nation. So like Central Health has just been like an incredible leader in providing access to healthcare for folks with low incomes, and comprehensive healthcare, like standardized by the Affordable Care Act. And so that said, I think there's a lot of room for Central Health to continue being a leader by taking the precedent that is already set, not just with Ham, but also with community members at large who are not necessarily part of a specific interest group, and offering healthcare access to those folks as well on account of their low incomes and their residence in Travis County. So the Central Health Assistance Program that gets people into Sendero and pays their monthly premiums is an excellent precedent for potentially a pilot of restaurant workers around town who also don't have like a specific organizing kind of like network the way that HAM does. HAM is so well organized and keeps people in touch with like what to do once they get covered and how to make doctor's appointments, how to file taxes appropriately because there's extra tax forms for folks who are on the marketplace. And then I do want to say also that Good Work Austin is, I think, uniquely positioned as a similar organization to make that transition from uninsurance to being funded or to being insured possible for people in the Central Texas area. So as Sharon mentioned, the low-income special enrollment period ended just this last Monday. So for folks who have incomes under 150% of the poverty level, they are no longer, as of Monday, able to enroll in health plans throughout the year, which just means that we will see continued devastating cases where people don't have access to health care because they don't know about it, because their incomes have never made them eligible or have never given them the opportunity to purchase health insurance. But the premium assistance programs offered by Central Health do that specifically. So what they really do is like they provide an incentive to people who otherwise would have no incentive to get coverage until they get sick, right? But then now, because we lost the low-income special enrollment period, those folks, their lives just sometimes devastatingly change afterwards. So again, just like big thank you to Central Health for the work that you've done so far. I think a pilot program organized through Central Health and through Good Work Austin could be like, thank you, could be like a really, really excellent opportunity to see how we can create that incentive for low-income restaurant workers now that we're losing other methods of enrollment and funding throughout the state and the local area. So thank you so much for your time.
Thank you.
And I appreciate your work. Yeah.
Appreciate it. Thank you.
Thank you, Lynn. Adam Orman?
Yesenia, how many more do we have signed up?
We just have one more after Adam. We have Manager Motwani going after.
Okay, and there was another individual signed up. If you can also call them back after the speaker.
Zachary Jebson, I don't see them online and I don't think they're here in person, so they may be coming back at 5:30.
Okay, no worries. Welcome. Sorry.
Hi. I'll make it worth your while, I promise.
No, I just want to make sure that everyone...
Hi, I'm Adam. I know. Adam Orman. I'm the owner of Locadoro Restaurant and Bambino. We opened Locadoro 10 years ago in Austin, and we were asked by, and I've been in the restaurant industry for 30 years, and I've never had traditional health insurance. I've been very lucky. We were asked by the city in 2017 to help write the paid sick leave ordinance to be in the working group, and one of the things that came up was, it's great, we get to pay our employees for staying home, which is important when they're handling your food. If you're just thinking about this from the guest's perspective, and we talked about healthcare because we don't want people to just be able to stay home. We need to actually have them get better, right? But that was not part of that working group, so the can didn't really get kicked. The can just got moved aside, and the can is still there. Nothing has changed. In fact, things have gotten worse. Lynn said that much better and laid that out much better than I can. But what we've done at Loca is create kind of a cobble together patchwork of direct primary care and a cost sharing community. None of our employees were interested in traditional insurance because it's too expensive. When we were trying to pay half, it's gotten more expensive over the last 7 years. During the pandemic, we paid for the entirety of their direct primary care because we didn't know it was happening. And we needed to make sure that if we were going to ask people to come to work, that they had access to a doctor. And that was $3,000 a month, which depending on the month was somewhere between 2 and 4% of our revenue, which is absolutely unsustainable for a small business to take on those kinds of healthcare expenses. And that was just for direct primary care, not full insurance. Everything has gone up over the last 7 years. Rent has gone up, food costs have gone up, small businesses are suffering, our employees are suffering, they are moving out of Austin, and they are still uninsured. And you see who's here. The folks who are here are local small business owners. The people the businesses, I'm not going to throw any particular names under the bus, but the places who can afford rent in Austin are not at this meeting right now. They are not asking for a pilot program to secure the health of Austin's team members, Austin's restaurant members who are paid $2.13 an hour, who have no guarantee of PTO, who have no guarantee of benefits at some of these multi-million dollar, multi-billion dollar companies that are feeding, in heavy air quotes, that are feeding Austin. Jeff, I think, laid it out nicely. We've had a couple conversations with some of you. I think a pilot program to prove that this works, to prove that Austin is the only city in America that is
30
trying to
seconds.
solve healthcare for hospitality employees, which is the largest private employer in the country, would be an amazing thing to have happen in this climate when the rest of the when we're seeing from federally that people care less and less about healthcare, about the most vulnerable people in our community, many of whom work in the bars and restaurants that you go to every day.
Thank you.
Thank you.
Appreciate it.
Thank you, Adam. Manager Motwani?
Thank you, Chair. I came to speak on two issues today. I don't think either of them is going to surprise anyone. In my time in Austin and well before my time in Austin, for reasons that are founded on lived experience, which you never forget, as well as professional experience, which is 30 years in nonprofit philanthropy and health and human services, I have been an unapologetic supporter of workers. And by workers, I mean frontline workers. I mean workers who are making the lowest wages, and even who are making middle wages, or what we call middle income wages, which we know in Austin is on the brink of not affordable, very much to the point of trauma for many families and households. That being said, I think everybody who's been in town remembers the study in the late 20-teens that said that Austin, it was a Dr. Chetty Equality of Opportunity study out of Harvard that said Austin is the most economically segregated city, or among the most economically segregated cities in the country. And I think we know that hasn't changed much. I think we're not surprised. Everybody knows we're heading into an economically rocky period. Those who have are going to be able to weather that period. Those who are on the brink of affordability are the ones who are going to be suffering. And that suffering cascades to future generations by means of trauma. And we are all blessed to have that information with us. Healthcare outcomes are a part of that, and access to those basic needs, or moreover, lack of access to those basic needs, is extremely catalytic in perpetuating this kind of injustice. And frankly, perpetuating the blocker on economic mobility, the ability to move from the bottom quintile of the economy to the top quintile, which is effectively non-existent here in Austin. It's for these reasons that I'm compelled to speak, well, first of all, on the budget priority that I submitted 2 years ago around doing a feasibility analysis and a potential pilot project to explore how we can at least seed a project to understand the feasibility of being able to support premium assistance programs, and possibly hand in hand with philanthropy, take that to scale. And I vehemently support that, and still do in this budget year, and I appreciate those who have come out to speak in favor of that. Secondly, we have heard from the Union of Workers at Integral Care around some matters, and given our increased investment in that organization, I believe it's 30 million out of maybe a total budget of 150 million or something like that. We of course have influence, in that organization by means of the board, but I think the amount of dollars that we are funding by means of fee-for-service contracts is high enough that we should look into these concerns. I think some of these concerns, again, are around living wage pay and equitable pay raises. There were some things that I noticed in some of the materials that were shared with me by the union workers who have come to speak here, and I've also seen them on other occasions, that I haven't heard necessarily fully addressed. And I'm not comfortable most particularly, both on the moral side, but the pragmatic imperative to fund an organization in fee-for-service mechanism when we are not sure that outcomes can be achieved due to staffing and vacancy issues and turnover issues that are resulting potentially from the wage issues that are being felt. So hopefully this board can work together to solve some of these worker concerns. I think we can. Thank you all so much.
Thank you, Manager Motwani, and we can discuss this further during our budget item.
Chair,
Yes, Chair Kitchen.
I'm happy to discuss it during the budget item, but I have information to share that Manager Motwani is probably not aware of on the last item he mentioned.
Maybe we can discuss it at our budget item because it's going to follow.
That's fine. It's just an informational item, and it's relevant to the people that spoke today also. So if you'll grant me a minute to do that. when
Sure,
it's time.
sure, Chair. You can have the full 3 minutes.
Well, I don't need 3 minutes. I'll just take a minute. I just wanted to to thank Manager Motwani for his concerns. I think that we all share them. I also wanted to let him know, as well as our board know, as well as the public to know, that tomorrow is the Integral Care Board meeting. They will be discussing the budget at that time. It is my understanding that at that board meeting, the CEO will be speaking to the wages of Integral Care Board members. So just wanted to let you know this is not an issue that the Integral Care Board is unaware of, nor the Integral Care CEO. And although I don't know what he will be speaking to the board about tomorrow, I do not know that that is on tomorrow's agenda.
Thank you for that. And we can discuss it further. Sorry? No,
I'll bring it up at the board meeting.
yeah, let's just discuss it during our budget item. Thank you, Chair Kitchen. Do we have anyone else in the room who wish to speak, who have signed up and have not been called on?
Is there anybody online I may have missed? I think we got everybody, and we have 4 signed up to speak. Oh, I apologize. 3 signed up to speak at 5:30.
Are they here right now?
They are not.
Oh, okay. Thank you. And I believe there was also Zach. You mentioned his name. Sorry if I'm...
Yes, I moved Zach to
Is that correct?
5:30.
Okay, just thank you so much. Okay, well, thank you all for taking the time to speak before us. We really appreciate it. Now I am gonna be proceeding to our committee agenda item. Agenda item number 1, approve the minutes of the July 15, July 23, and August 12, 2025 Budget and Finance Committee meetings. I move that the committee approve the minutes of the July 15th, July 23rd, and August 12th, 2025 Budget and Finance Committee meetings. Do I have a second? Manager May seconds. So when I spoke, I made the motion, so we have a second. All in favor? Any questions? All in favor?
Aye.
Aye. Motion passes. Thank you all. Now we are gonna move on to agenda item number 2. Receive the July 2025 financial statements for Central Health. Members, there's no presentation on this item. Materials were included in your backup, and staff are available to answer questions. I just want to bring one item to your attention, that the statement is that the UT affiliation agreement payment was occurred in July for $35 million. That payment is due on August 15th, and it has occurred a month in advance. So just wanted to update you on that, and we can have further discussions when we talk during our budget item. So moving on, there is no motion for this, it's just informational. Now moving on to agenda item number 3, receive the July 2025 financial statements for Community Care Health Centers. Dr. Nick Yagoda and Joel Sloan will be presenting. Well, welcome. So just for note, Dr. Yagoda, you have a hard stop tonight. Is that correct?
We have, yes, but not for another 45 minutes.
Okay, just want to be sure that we are mindful of your time and
Appreciate
board members get to ask any relevant questions to you.
Yeah.
Well, welcome and proceed.
Good evening. Thank you for having us today. We're excited to show you our July numbers and fiscal year to date, which will demonstrate that we are doing better than we had thought we would be doing at this point in time. And so we're excited about that. Pardon? Closer? Okay. Yeah. Okay. Is this better? So if you'll go on to the next slide, please. For the first 10 months of this fiscal year, we're currently at about a $3.5 million operating loss. We really expected to end the year closer to, I think, 12 to 15 million in the hole. It's going to be closer to about 4.7 million now. So we've done some internal work on containing cost, as well as really working our pharmacy revenue significantly, looking at every way that we can possibly bring in some additional revenue. And we continue to do that through the end of this fiscal year. Certainly, that does include the 2.8 million that Central Health has already put into the organization to help offset some operating losses for locations. And we'll be closing that gap by the end of the fiscal year, but it will be much better than what we anticipated. Next slide, please. When we look at the balance sheet for July, we did see days cash on hand drop to 34, but that's because there were 3 pay periods that came out in July. We fund the pay periods in July. The staff get paid 3 times in August, but because of timing, we did see that hit our cash. There were no other really significant changes on the balance sheet for the month of July. Next slide, please. And when we consider our encounters, they do continue to run under budget, but we are actually onboarding quite a few providers. We had 4 providers come on board in July. We have quite a few more coming on in August and September. So that has been very, very helpful towards setting us up for success for the next fiscal year. And so we still, while we still have some work to do on hiring and retaining and our incentive plans, we're seeing some really good progress working closely with HR for hiring options. So next slide, please. Our pressures have not changed this year, and they're going to be ongoing into next year, but I do feel like we've got a very solid plan to mitigate those in conjunction with Central Health. In relationship with that, we've got several things in the works that we're very excited about. So I think that as we face the pressures of the last few months of this year, fiscal year 26 is going to be much, much different in how things run. So that will be exciting. Are there any questions on our financials?
Once Dr. Yagoda speaks, I'll open the floor.
I just want to give credit to Joy and the rest of our SLT team on what was a year of very, very difficult choices. Being able to cut that deficit of up to $15 million in half is not a small task. Part of that also involved deep partnership with our Central Health colleagues and Jeff Knodel and John Morgan and others who helped us figure out best ways to navigate what was a very complicated situation. I think this is a testament to how we, as an integrated system, are able to weather turbulent times to a much greater degree than were we to be operating separately. I'll just leave it there. We'll get to the budget shortly.
Thank you. Appreciate that, and appreciate all the hard work you're doing in light of this challenging climate. Thank you. I'm going to open the floor. Anyone has questions? I see Dr. Martin.
Thank you, and thanks for the good work. I had a question, just educational for me. The cost for HIV/AIDS, cost per encounter is really high. Why is that so different? Lab or?
Okay. We consider the HIV care team to be part of what we call intensive outpatient care settings. And so these are very resource-rich clinics. Dr. Brinson, you can probably attest to what has been a funding model that is rather unique through the Ryan White program that allows for more whole person care than traditional primary care has largely been paid to do. As a result, we have substantial additional funding to wrap our patients with a larger care team that attends to the non-medical drivers of health much more intimately than is available in traditional primary care.
Thank you. Also, I just noticed that the total encounters fell by 11%. What was that due to?
Total encounters down by 11%, is that what you said?
Yeah.
Yeah. So this is related to a number of different factors. There's recruitment elements to this, which we've spoken to you all about over the past year or so, which we, to one of the points that was on the prior bullet point, are undergoing a wholesale rehaul of how we do recruitment and retention work within community care, within the system writ large. We also encountered a number of different pressures around access to care, which will be addressed through our focus this next year on a full year, the year of access, as we're calling it.
Manager Jones, then Manager May.
Yes, thanks very much for the report. How are you calculating in, or are you calculating in, the Black Men's Health Clinic in terms of some of these numbers? Are they part of the primary care system, and therefore, is there any way, not now, but at some point, you can fester that out so that we can be able to see those numbers?
Yes. Yeah.
Okay. Thank you.
Thank you. Manager May. Do you have any further questions, Manager Jones?
No.
Okay. Manager May.
Thank you. Thank you. I really appreciate the report. More importantly, what I really appreciate hearing that we're making progress with this integrated system model and reducing our cost, and that's been a piece of it.
I'm sorry, did you say the centering?
Huh?
Can you repeat what you just said?
I
Making progress on the centering system?
No, on the integration that has been happening as a result of working closely with Central Health, working with our team here at Central Health.
Yes, ma'am.
But here's my question. Do you expect, and I know it's a very turbulent environment, but do you think as a result of having this closer relationship and being able to hopefully in the future even work much closer with all the different teams and the model itself, do you expect that you might be able to close some of that gap where the losses are?
Without a doubt. Access to care is a very exciting topic for us and involves many different features. There's the direct clinical care. There is the navigation when patients are at home, calling into the system, going between different provider groups. The more integrated we are, the more we use the same electronic health record to communicate with one another. The more we use standard workflows across the system, the more seamless it all becomes, such that our ability to respond to patients in more real time is going to be much, much easier than if we were on separate systems. We see that when we have difficulty navigating patients from the hospital into our system, or from specialists outside the Central Health Community Care Network into our system. This will allow us to close that financial gap through a higher productivity, higher efficiency, but actually easier care for our care teams as well.
Well, thank you very much for your work on that, and at the end of the day, I'm sure that that's helping our patients most.
We hope so. That is our intent.
Thank you, Manager May. Any further questions? Manager Valdez.
Just based on what we're seeing, the economic downturn for those that are at the lowest rungs of the socioeconomic level here in Travis County, is there any support for expanding services for the various populations that we have heard from today, including HAM, including the hospitality and food workers, including contractors in the, in the construction world, all these people who live outside the parameters that average residents and citizens are living in, because they're not going to be able to support another year. They're not. And I sure don't want to have to go to another budget year where we are not going to be able to tell them this year that we're working on expanding services, including them providing increased enrollments in maybe new categories, expanding MAP numbers, or some new, maybe a different category of MAP to accommodate the needs of these who are living outside. They're living in the shadows. They're living below poverty, below anything. So
So-
I just, I'm torn. I'm just
I'm
so
with you. I'm
upset
with you.
about it.
I'm with
know?
you. Thank you for the comments. I have two thoughts. First, that I'd like to say that is our specialty, to work with communities who have been forced to live in the shadows, and bring them out, give them access to care in a way that they have not been offered before. Secondly, our ambition, we're an organization who year over year is averaging at least 7 to 8% growth in the number of patients served. We anticipate we should be able to continue that growth. And as part of our larger strategy, the fact that we are a system that is based on a payer in the MAP system and a provider in the Central Health and Community system, sitting around the table deciding where we need to create greater access of care allows us to be more nimble than any other health system that I'm aware of. And that is a great benefit for us as we look to bring these different communities into our wrap. Yep.
Thank you. Thank you for that. Any further questions? I see Chair Kitchen. Do you have a question? Okay, perfect. Do you have any questions? So I don't see any further questions. I have a quick question for
Sure.
you. In terms of your hours of operation, and as you know, many of our population are not traditional workers. They don't work 8 to 5 jobs. So do you typically offer after hours?
We do.
On the weekends?
We do.
Can you share that?
Yeah.
quickly?
Well, I don't have all the different sites that are open on the weekends or after hours. There are many different ones that are open late into the evening, even early in the morning before school drop off, and certainly on the weekends. As we go into this next year of access, this is going to be one of the questions we're going to analyze is not only how are we efficient with the time we do have, but can we actually expand the time? The recruitment of a workforce that wants to work in the evening or on the weekends is a very different type of recruitment. We've had some challenges with that in the past, but I think if we put all of our heads together, we can figure out ways to bring that level of access. And we need to know that that is in fact what the community wants. There are some that do, there are some that don't, but this will all be part of the calculus that we undertake in the next year.
Thank you. And if that information could be available to the public somewhere that is accessible, I'm pretty sure it is. But
The hours of operation?
yeah,
Is that
but
what you're asking? Yeah.
if it is like rather than
Post it.
digging through some files, whatever, online, some pages. Thank you. Appreciate it.
Absolutely.
So there is no motion for this item. I am moving on to agenda item number 4. Receive and discuss a presentation on the proposed Central Health fiscal year 2026 budget and tax rates, as well as the fiscal year 2026 budget for community care health centers. At this time, we'll have Dr. Lee, Dr. Nick Yagoda, Joy Sloan, Jeff Kanoda, and John Morgan will be presenting. I believe Dr. Lee will open it.
Chair, with your permission, I think Dr. Yagoda and Joy Sloan were going to present the community care component, and then I could go next, or I could read the opening statement, whichever you prefer.
I thought you were gonna overall, if you can, few words, opening statement.
Let me share a few opening words, and I'll head over to both of you. So thank you, Chair and Managers. As we continue our discussions on both the Central Health and Community Care fiscal year 2026 budgets, I want to first reaffirm our unwavering commitment to ensuring that all of our patients have access to high-quality care through a strong and resilient integrated healthcare safety net system. Our responsibility is both urgent and essential. Across the nation, health systems like ours are facing growing challenges, declining funding from federal, state, and philanthropic sources, combined with increasing regulatory guidelines for patients eligible to receive the services of a safety net system. Travis County is no exception. Despite these pressures, we remain steadfast in our mission. Together, Central Health and Community Care will deploy over $1.1 billion in FY 2026 to strengthen access while improving outcomes and investing in the services our community needs. This includes expanding primary and specialty care, deepening our commitment to behavioral health, enhancing services for individuals experiencing homelessness, and planning for acute and post-acute care capacity. These are critical areas that touch hundreds, many hundreds of lives every day in our community. To make this vision possible, we are recommending a property tax rate of 11.8023 cents per $100 of assessed valuation. This is an increase from FY 2025, and we recommend it deliberately because we believe and we can demonstrate that the return on investment to the community is substantial. This budget is not just about numbers. It's about expanding access to care, reducing inequities, and ensuring that those who rely most upon us can live healthier and fuller lives. Thank you for the continued dedication, support, and your leadership as we move forward in these important discussions.
Thank you, Dr.
Welcome,
Lee.
Dr. Yagoda.
Dr. Yagoda.
Thank you. Just as a moment of recognition of how this budget year has gone so differently than in prior years. As you all are aware, in the last year, we've spent substantial time as a system figuring out what is most important to us and how we can each contribute to those priorities for us. We have called those our OKRs, or objectives and key results. It has driven a type of alignment that has us focusing on the things that are most important for us, and from that, the budget was developed. Rather than building a budget on what we have traditionally done, the budget is now focused on what we wish to do. That has led to a philosophical transformation in our relationship at community care with Central Health, in which we are now going to shift the payment scheme so that we are paying for the value of the work that we are doing collectively, rather than the volume of widgets that we have historically done, which grossly misses all the essential elements of what must be health service delivery. So this has taken a great deal of work and a great deal of creativity and flexibility, and so I want to extend our gratitude to Dr. Lee, and again to John Morgan, and to Jeff Knodel, and all the other ELT members who have helped imagine what might be a more effective way to pay for care so that we can deliver the things that are most important to us. Joy will go through some of those details, and then we'd be happy to take some of those details, recognizing this is in a larger context of what the Central Health team will present afterwards.
If you could proceed to the next slide. So our community care budget is based on $270 million in revenue and $270 million in expense. I think we have about a $300,000 projected surplus. And that was arrived at by looking at the medical providers, dental providers, behavioral health. What kind of staffing model do we need from a care delivery perspective that then drives encounters, and that drives staffing cost from there. So looking at that, we saw an increase in third-party revenue and pharmacy revenue tied to encounters. We're projected to do, I think, about 440,000 encounters this year. We're budgeting about 600,000 next year. And that does account for the shift in Medicaid payer mix. We're holding that at 25%. And it does account for the shift in the pharmacy lost margin. And to account for that, Central Health contract revenue then increased 21%. That is tied to an increase in encounters for MAP and MAP basic patients, as that's projected to be about 45% of our total encounters. And we saw grant revenue decline from historical numbers because all of the COVID-related grants that we received during that period of time are now fully expended and no longer available. So our grant dollars have returned back to pre-COVID numbers at about 16 million. Next slide, please. When we look at in the encounter growth, it's about 14% from our fiscal year projections. I'm sorry, there's 526,000, not 400. We have most of that growth is going to be in our medical area. We are onboarding, as I mentioned, quite a few providers. We have quite a few more to onboard. And but we're also expecting considerable growth in behavioral health, with a little bit of growth in dental and therapies. Therapies are occupational, speech, and physical. And we expect our payer mix to hold at about 25% Medicaid and 3% CHIP, recognizing that that could be in jeopardy depending on what happens with undocumented status. And then we are, as I mentioned, we're expecting then the patients to fall more into MAP Basic or uninsured categories as they shift out of the other payers from Medicaid. There could be an impact in our ACA plans if we see a lot of patients unable to find that affordable. And those patients would then either shift into MAP or MAP Basic or uninsured, depending on how that works. The next slide, please. Our total expenses are projected to increase 11% from fiscal year end projections. Wages and benefits, that's the majority of our cost expenditure. And we do include market and merit increases as well as growth related to unfilled positions and new positions. Our contract labor went up slightly. That's because we moved some of our previously hired positions for our convenient care locations into contract labor. Pharmacy drug costs, it's related to the revenue we expect to generate. Direct patient supplies and contracts that increased slightly. That's based on encounter volume. And our indirect cost went up slightly. We are moving some of the Epic software cost back into community care. And we have some consulting services for value-based care work. But the majority of our expense increase is in our wages and benefits and staffing model. Next slide, please. When we consider personnel cost, it's a tendency to carry forward positions year over year that you don't fill within your budget because you don't really want to let them go. And this year we did a deep dive into our budgeted positions that we've just never filled or just been carrying for a while. And we also talked, as we worked with Central Health on collaboration and integration, we were able to move some position costs into Central Health that made a lot more sense from an alignment perspective, such as financial screening, employee education and orientation. That saved some expense on our books. And then we also were able to cut out positions that we just didn't feel like we needed that to carry our structure into the next fiscal year. This is all without losing staff. This is all without affecting filled positions. And we did add in some positions into our budget for fiscal year 26 that are going to be crucial to moving us into the direction we need to go from a patient access standpoint and a support standpoint. But that 1.5 million was really offset by about 9.8 million that we cut out of the budget. So as you can see, when we're looking at our fiscal year 26, we do have vacant provider positions that we're expecting to carry into the new fiscal year. But that's about, I think, 8%. And we budgeted about an 8% vacancy rate for our providers, knowing that we would have turnover or some potential open positions going into the new year. Next slide, please. For the Central Health funding arrangement, we're still working out the details on that. The commitment for community care for the next fiscal year is $98.8 million. To help offset and allow us to build toward that access capacity. In previous years, that was paid for on a billing perspective, claims-based perspective, and then some contracted services. We're looking at a 1/12 of the budget amount going into fiscal year 26 with a true up to cost and expanding the services in which we're providing to MAP Basic and expanding that population that we're serving. Next slide, please. So the challenges will still be there. I want to be clear that the budget is a guide, and it was prepared many months ago. So as we look into the new fiscal year, we'll use it as a guide, but we will also be very heavily investing in projections and analysis to see where we are and where we're going, and let that guide the decisions going forward. While the budget kind of anchors us to make sure that we stay true to what our goals are for the next fiscal year.
Well, thank you. Does that conclude your presentation? Appreciate it. I have just a couple questions before I open it. In terms of your personnel costs, do you have any positions for community health workers? I'm just wondering, that is something that I don't see it here, and that it's a tremendous need for our patient population in terms of community engagement and outreach.
Yes, we have not detailed the full range of different staff types, but we have an abundance of community health workers. We don't have enough, to be frank. If you imagine what the future of healthcare delivery should look like, it is much heavier on the community health worker side, but we have certainly invested deeply in that in the last number of years.
Okay, perfect. I believe that is, and this may be of relevance to everyone, and especially what's happening. The current CDC director was just ousted. So that tells you a lot about the future direction of healthcare and public health in this states. So I just wanted to point that out. So I am going to open the floor to board members. I'm going to take the online folks. Chair Kitchen.
Okay, can you all hear me?
Yes, we can.
Okay, sorry, I'm having trouble with the controls here. I have a question. I'm not sure if I understood on the slide where you were talking about the 1/12th. Are you meaning to say that the way the payments will be made between Central Health and CUC is that they're monthly upfront?
That's
with
right.
With a true up afterwards? Is that what I understood?
That's right. I noticed that as well. There's a key word missing, which is that we will do monthly 1/12 payments to represent the full, over the course of the year, the full amount.
And is the true up at the end of, what is the time period for the true up? Is it at the end of the year or at the end of some other time period?
Yeah, we're still working out those details between Jeff and I. I think what we're most concerned about is making sure that we maintain days cash on hand levels to 30 or more, and then looking at what the cost would be or if there would be additional money used, or quite honestly, if we perform better, maybe there's less investment needed over the course of the year. But I think Jeff and I are still working out what that cadence would be.
Okay, then last question, Chair. And y'all may still be working this out, but when you're truing it up, are you truing it up against a fee-for-service model or some kind of value-based model?
We have, so this year, we would true up based on what the total budget was, and this budget was developed based on how we have worked in a fee-for-service relationship. So we can imagine that over time, this evolves as we shift to more value-oriented framework, but we're just in the very beginning stages of using these annual OKRs to really help establish what must be for us to realize our aspiration and build care teams around that. So I would imagine over time we see a shift towards more of a value framework, but being that it is paid on a monthly basis, a 1/12 amount, as opposed to a volume basis, we've already taken a gigantic leap towards more of a value framework.
Yeah, I understand that. I was just trying to figure out if there was your monthly amount in your budget is based on a fee for service as opposed to a fee for service plus some built-in incentives. But I understand what you're saying.
Correct.
And so okay, I got
Yeah,
you. Thank you, Chair.
the basis was prior budgets, which was fee for service.
Thank you.
Thank you, Chair. Thank you.
Thank you. Manager Rodriguez, do you have any questions?
Yes, just one question. I think as we are all trying to, as you all are all trying to integrate the healthcare system, I'm just curious what the definition of days on cash on hand are for you all, because I'm trying to just compare the definition of Central Health days cash on hand and you all's days cash on hand. So I was just curious if you could share the methodology. And it doesn't have to be now. I mean, you can share it later if it's not available.
Actually, we average the last 12 months of expenditures, cash expenditures. We average those and divide that into the cash balance to come up with the days cash on hand.
So,
which is different than Central Health, if I understand correctly.
Correct.
Okay.
Got it. Okay. Thank you.
And that varies by every fiscal year, but
Well, because it's a rolling 12 months, so it's a rolling 12 months of our cash expenditures. Yeah. So it'll vary.
The amount will, but not the methodology.
Correct. Yes, absolutely. Yes. I
But
was
the
referring to-
methodology is different than that of Central Health.
Correct.
Yeah. Sorry, I'm just trying to compare standardized kind of process or definitions
Thank you.
so that when we're looking at one budget, we can understand the other budget as well. Thank you.
That's a great point. If possible, Jeff and Joy, if you can send us out like a memo determining that, I think it will be helpful for board members. We would appreciate it. Thank you. So, no further questions, Manager Rodriguez? Okay, Manager May, I'm gonna go from the side.
Thank you. So this has to do with the raises and merit increases line item that you have on here. And more importantly, what I'm really looking at, in light of the testimony, public testimony we received earlier, are the merit, your raises that you're going to be providing your staff, are you doing a percentage across the board for staff, for all staff? And then, and if you're not, then I want to know, I'd like to hear, and I'm sure others would too in light of, again, the testimony, what process are you using so that it's as equitable as possible for all employees?
So the current process is that we do annual reviews, and then the merit is based upon the outcome of that annual review. That's the current process. So it could be up to 3%, depending on how you rate within that annual merit review, within the annual review, performance review.
So it's a combination of performance, right?
Yes.
It's not necessarily an economic across the board, like a COLA or anything like that?
Correct.
Okay.
Yeah.
All right, very good.
Yeah.
Thank you.
Yeah.
And that leads me to another question. Thanks for Manager May. Now, for instance, an MA, for instance, are they equivalently paid at Central Health as at CUC? Is it the same standard payment? I'm just wondering if there's any
Great question.
discrepancies.
Because our service lines have been different, there has been differences based on purely the definition of MA, but their scope of responsibilities is different. And so what we're undergoing right now is an assurance that the portfolio of responsibilities that all the positions hold matches no matter where they're sitting in the organization. And this is true even for common positions that might exist between Community Care, Central Health, and Sendero. The idea is that we are now blending into a common philosophical approach and a common benchmarking for all the different positions. That is a work in progress right now.
But the question is, are they paid equally? Are you all competing for the same pool of employers? Like, would they rather go to work with Central Health than CUC? I'm just trying to understand. If Central Health pays more, I would rather probably go work for them rather than CUC.
Because the service lines have been different, it has been difficult to answer that because, for instance, the Bridge Clinic working in respite settings is just a type of setting we don't have and a type of complexity that we don't have. So really what we're trying to do right now is really balance those portfolios, make sure that we have a clear understanding that we are measuring apples to apples and not apples to oranges. I will tell you that hasn't always been crystal clear to us over the last year, and so that's why we're undertaking this process to make sure we're all on the same page.
Okay, so perhaps in the future you can update us on that.
Yes.
Manager Jones.
Thanks very much for this information. But a comment to what you were saying, and also Manager May, and the system we operate under, this is an extremely complex process. And for those of us in the room, some of us may not understand all of it. Certainly those in the community is not. So is this our budget, meaning community care, or is this our budget Central Health, or is this our budget Central Health as community care as part of it?
Great question. This is our budget as the health center program together that must be a budget that is approved by this board with final approval landing with the community care board. So this is something that has to be developed collaboratively. So when I may be dodging the question somewhat, but realistically, it must be jointly approved.
No, I understand you're in a very unique position to have to try to negotiate this. And this, Dr. Lee, is part of the challenge we have with our community understanding where we stand on this. having said all of that, and I'll leave that for later, did we incorporate into this those recommendations we had, particularly for enhancing the Black Men's Health Clinic in terms of these positions, or are they going to be part of our central health component?
So Central Health and the Black Men's Health Clinic, that the portion that is for funds to flow to community care is part of this budget. And that's the clinical operation of the site.
Okay, so those discussions we had with enhancing what we were going to do there with the Black Men's Health Clinic are included here.
They should be
Or
included
should be
here.
here,
Yeah,
okay.
the portion that is relevant to community care is service
Because
delivery.
I look at this, I remember we talked about a nurse practitioner or someone in terms of enhancing services.
To expanding services, expanding the number of providers. Yeah, so forgive me, I can't recall. I don't believe the position is in this budget. We have anticipated that as we get cross an access threshold, as we do with any service line, we will then add on additional providers. So this is part of the normal expansion track that we have clinics on.
Okay, I hear what you say, I understand what you say, I trust what you say. But when we get into next year, when we find ourselves very tight for money, and we're having demands from my community and others, that we enhance those. I don't want us to hear, well, because this year we have this tight fit, we can't do that.
Yes, I hear what you're saying. And the fortunate part is that particularly in providers, as in this case, they're revenue generators when it comes to other payer types. And so those are much easier to approve, the expansion of, frankly.
Okay, I'll hold you to it, too.
Okay.
So would it be possible if you can provide, even to us board members, a clarity? Because to me personally, I'm confused. It's not clear what Central Health is responsible for, what community care is responsible for. So if you can have like a flow diagram, a workflow, like, it would help us.
Yeah.
Can
Happy
you
to.
provide that?
I believe Jeff and his team will be able to provide further clarity on that
So
distinction.
that's going to be on their end, Central Health side?
Yep.
Okay, all right then, that's fine.
I just need to look, see where we're in.
But, yeah,
Yes.
I do think it would be helpful, we could do a matrix with positions and Central Health
Yeah,
funds
just-
this, community care funds that, and so on and so forth. Okay.
And it's for transparency. We
For
we
transparency,
understand.
yes, exactly.
So
I-
go ahead.
Okay, I think that was the only question I have with regard to you all, and
Thank you.
I commend you because you have a very challenging job this year.
And I return the favor. Your job is not unchallenging either.
What's that?
Your job is not unchallenging either.
Oh, tell me about it.
Thank you, Manager Jones. At this moment, I'm going to pause to take public communication. It is 5:33 p.m., and then I will move on to the other board members. So you can step aside a little bit until we call folks, because we have folks in the room for public communication, and we'll call you back, so it should be short. Yesenia, can you read it out? Because
Yes, and while I read it, Aloki, if you can just come up to the table, and I'll read this evening's public communication guidelines. When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please
Turn on your
indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when each speaker has reached their time limit to ensure the efficiency of the meeting. Once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. And thank you so much for being here, Loki. You have 3 minutes.
Thank you. My name is Aloki Shaw, and I'm the president of the United Workers of Integral Care. I'm here on behalf of the frontline workers who run the mental health and IDD system in Travis County every day. I'm asking you today to invest in integral care, specifically to provide supportive funding for wage increases for the lowest paid workers, the workers who are struggling to make ends meet. Right now, low wages and high vacancy rates are taking a serious toll on services. When positions remain unfilled or when staff burn out and leave, clients feel the impact directly. Clients are pushed to lower levels of care not because their needs are less urgent, but because staff vacancies leave no one available to provide appropriate support. Increases to the wages of the lowest paid workers will decrease understaffing and turnover in the workforce and in turn service delivery. At this time, waitlists for therapy are closed more often than they are open, a problem in itself, on top of the fact that an agency such as ours has a waitlist in the first place. Those with the highest needs are often unable to connect with ACT teams for the specific type of intensive care they require and deserve, and so you see these folks cycle in and out of the carceral system, in and out of homelessness, in and out of hospitals, in and out of stability itself. This is incredibly burdensome not only to the individual, but also the cost that these alternative systems have on the taxpayer, your funders. Fair wages would give Integral Care a stronger edge in attracting not only skilled staff, but also donors and foundation partners. Philanthropic funders want to invest in organizations that demonstrate stability and strong workforce retention. If Central Health is able to put forward an investment towards a significant and meaningful increase to the wages of the lowest paid workers, you may actually see less need for Integral Care to rely so heavily on Central Health in the future. Right now, Integral Care is regularly denied foundation grants because they cannot demonstrate living wages, good working conditions, or even basic supports like a healthy environment for parents. We lack benefit and we lack wages. The wage increases that have occurred recently, such as the 4% raise last year, have not been equitable or addressed the low wages on the front line. We also need to be realistic about the broader funding environment. Federal grant opportunities are shrinking. That makes it all the more critical to retain the workforce we already have and to show potential funders that this organization has a stable, skilled staff. Every dollar you put towards wages today translates into greater organizational stability, which means stronger leverage for tomorrow's funding opportunities. The bottom line is this: the lowest paid workers are the foundation of our mental health and IDD system. They are the ones doing direct service care. There's so many people in our community who depend on our services and so many more who cannot access them because of staffing shortages. You can have all the executives and administrative structures in the world, but without the people who are actually taking care of clients every day, there would be no agency at all. Without stability in the workforce, services falter. So on behalf of the workers in the community we serve, I urge you to prioritize investment into wage increases for the lowest paid workers at Integral Care. I'd also like to express my deep gratitude for all the support that Central Health has given Integral Care and our community through a deeply tumultuous time we're going through as a country and always. With the most sincere and deepest gratitude, thank you.
Thank you.
Thank you, Loki. Up next, we have Cole Weaver. Thank you, Cole. You have 3 minutes.
Hi, my name is Cole. I am also a member of United Workers of Integral Care. I just want to make a few quick points, and that is, besides the fact that I mentioned last time I was here that the investment in mental health care is frankly long overdue. And I mean, I could point to another threat to our mental health systems by the executive order that is trying to defund a lot of services that, you know, are for the people that we serve. So it's very important that organizations like Integral Care are properly invested so that we can continue to address the mental health crisis. I also want to make a point that in terms of our salaries for the frontline workers, it's not even meeting what MIT calculated as a livable wage, which is about $24 an hour. The majority of Integral Care workers make below that. I, as a peer support specialist, make at least $20.83, and I know that sounds, I guess, decent if you're not living in Austin, but we are working in Austin. We are in one of the most expensive cities in the country, and it's not livable. I have other peers tell me that they cannot afford to live here. They're constantly, trying to just make ends meet. And my last point is this work means a lot to me. It means a lot to my recovery as a peer support specialist. And I want to be there for the people that I serve. A lot of them are going through challenges even worse than even what I went through. And I don't want to abandon them. I don't want to have to lose my job just because, Integral Care may or may not, make decisions with its funding, or maybe I might have to make a decision for myself of not being able to stay at Integral Care. So I do want to thank Central Health for, all that it's doing for Integral Care, and that's all I have to say. Thank you.
Well, thank you for your voice, for your compassion and empathy and everything that you do.
Thank you, Cole. Up next, we have Cole Weaver, who, I'm so sorry. We have Marcus Myers, who is online.
Hi, good afternoon, evening. My name is Marcus Myers. I apologize I couldn't be there in person, and I'm unable to have my camera on right now. I wanted to kind of, speak on behalf of Black Men's Health Clinic. I'm actually a patient of theirs. I was born and raised here in Austin, went to the University of Texas, was fortunate enough to also be a scholarship athlete there and play on the 2005 national championship team. And generally speaking, I have, what would be deemed on paper as pretty good health. But I do have, a history of cancer and some other things in my family. And so being a Black man that's now 41, I've put a lot more emphasis on my health. I've seen some people, close to me in age pass from things that were preventable. And I've really taken to the care that I've received under Dr. Taylor Jenkins at Black Men's Health Clinic over the last couple of years. And I just felt it was important to kind of voice my support of the work that they're doing there because for me, it's been one of the first times in which I've truly felt seen in a medical office, outside of, my football experiences. Oftentimes I've felt kind of rushed or overlooked. Someone will look at my chart, but won't really ask in-depth questions about things that I'm experiencing to, figure out what a tailor-made, plan for me would be. And so I had a completely different experience under Dr. Jenkins. He allocated plenty of time to, really walk through my medical history and my concerns, and gave me an opportunity to have an actual dialogue with him. So I very much felt like, a person that's experiencing this life, with someone in that space as opposed to just a number that, was trying to be rushed through the process. So my hope is that, my advocacy for continued funding for the work that they're doing, ends up being something that you all take into consideration. And I greatly appreciate your time. Thank you.
Thank you.
Thank you, Marcus.
Do we have anyone else?
Yes, we have Zach Jebson,
okay.
who is online.
Thank you.
Hi, Zach. You have 3 minutes.
For sure. Thank you. My name is Zach. I'm another member of the United Workers of Integral Care, and I work at Integral Care as a caseworker. I've been working there for about 3 months at the Community First Village team, which means that we work with people who have experienced chronic homelessness, and I'm here to advocate for better wages for our frontline workers, as Alogi and Cole have done. Frontline workers at Integral Care need and deserve higher wages to support ourselves. If Integral Care does not approve higher wages for the frontline workers, our personal issues will snowball and subsequently affect workers personally. This effect will be felt by our clients. Underpaying workers forces us to seek other means of income or employment. This will cause us to burn out more quickly than if we were simply paid enough by our employer, Integral Care. This burnout will also result in greater staff turnover, which is much more costly to Integral Care than simply paying the workers they have more. Understaffing will also result in worse care for our clients. Personally, I can see now how this is affecting my team. All of our case managers have full caseloads, which means essentially that we cannot take in new clients, which also results in less clients case managers and Integral Care serves, which is ultimately a net loss for both parties. Personally, I've felt the effect of these wages. I've only lived here in the time that I started working, which was in May, but due to what I am paid, I have to use smart housing options granted by Austin. I've also spent a good chunk of my free time doing odd jobs to help support myself. This need is further emphasized by the housing prices in Austin. With prices being so high, it falls upon Integral Care to assist us by paying its lowest paid workers more. That's all I have. Thank you for your time, and I appreciate you listening.
Thank you, Zach. Appreciate it.
Thank you, Zach. I believe this concludes this evening's public communication, unless I missed anybody online.
Have we missed anyone? I don't see anyone in the audience, so I think that's it. Thank you all for coming before us. Appreciate it. And you all still have another opportunity at our next meetings as well. Okay, so thank you. We're going to be proceeding to back to our agenda item, and I believe Manager Motwani, it's your turn.
No questions. Thank you for the presentation.
Thank you. Dr. Brinson?
No questions.
Dr. Martin?
Yeah, first off, I think it's just phenomenal y'all are work coming together with Central Health and you guys. I think it's going to lead to such efficiencies. I did have a question about the value-based care. How much of that is already part of your income generation? And that's, from what I've read, going to be exponentially increasing. How much does it represent already in terms of your income?
Currently, value-based is a very small percentage of our revenue generation. We have some value-based incentive programs with some of our commercial payers, but it's not a lot of money. What we're moving into is more value-based arrangements that take in the total cost of care. So we expect that to grow.
Okay, thank you.
Thank you. Manager Valdez?
Thank you all all of you, for your presentations. I'm waiting to hear from Central Health. But in light of everything that I've been hearing, I did suggest in something that I sent to y'all at Central Health that when we receive our budgets, that they be combined with a separate Central Health budget. Then we see the community care budget, but it all together, and not necessarily a different document, or the same thing with Syndetto, because we're talking about an enterprise. It almost needs to be it needs to be an integrated budget. I don't know.
Well,
for me, just to be able to see all the numbers together, like for instance, when I look at the healthcare delivery amounts, and I see Central Health, the total amount of our budget, and then the healthcare delivery amount may be 49% or 39%. Then I look at Community Care's budget, and their healthcare delivery costs may be like 79%. I'm looking at that because in my head, I want to, if I'm an average person, I want to be able to understand, why are we not spending more money on healthcare delivery as people are coming to us begging for more access to services? And maybe it could be that's just a philosophical question, but I think it's a very real question that people would be able to better understand and see. Me, $35 million to UT when we could be spending that on something else. I have a lot of suggestions for how we could spend that. And there would be direct services provided to those that need them most, not to the Board of Regents. But anyway,
thank you.
I just wanted to also, and just on another side, with respect to how our HR component, our FTEs are handled. I've asked for many years, I had asked for the actual, if you look at their administrative chart, these are our different levels or categories of workers. These are the job responsibilities. This is how much money that job is equal to in regards to pay or salary. And then you look at, as we're integrating, you need to be able to see how can a case manager here be making so little as opposed to a case manager here. When you're in the medical field, we know what a case manager is and pretty much what they do. And so I just am making a suggestion that for the future budgets and as you all are right now formulating how we are going to move forward in this integrated system, that we look at those kinds of things. So
Thank you for that. You know, I've thought about something right now about the way how we're even, well, first of all, there's 2 other boards that need to approve their budget, so that's why it's separate. But what I'm thinking, perhaps the way our tables or how we're presenting, maybe we can dissect, like just kind of, sorry? Another column of what each entity within our enterprise we are paying them. So I'm just thinking within our full budget, if we have 75 million, I'm just throwing out a number, X amount is for Sendero, X amount is for community care. I think it helps more for people to understand and transparency as we're looking into heading with this new health system of care. So would that help you kind
yes,
of?
and the reason I've been thinking about this is because I can see where the majority of the healthcare access and services are going to go. The responsibility is going to fall upon those at the local levels. We're not going to get it from the state, and we're not going to get that support from the feds. So if we have an entity like an Integral Care that had counted so highly on so much on a state system that is no longer supporting them, well, how are we going to include a comprehensive, fully integrated healthcare system in Travis County if we are not adequately funding those different compartments or departments or
Yeah, so I think the way how we're presenting the information.
for our most valuable,
might be
our most vulnerable
helpful.
population.
Thank you, Manager Valdez. So, Jeff, if there's a way that we can present it differently across, but each entity, organization will need their own budget for their board to vote on. Dr. Lee? Question.
Sure. So thank you for that invitation, Manager Valdez and Chairman Said. You're absolutely correct. We do have a need to present the health center budget as its own budget and the Sendero budget's own budget. But this notion that the public deserves and wants to understand what's the big picture here, right? What is the total amount of revenue sources that are coming into the central health system? What is the total amount of uses and expenses that are going out? How many total number of people are receiving healthcare coverage, whether through Sendero or through MapMap Basic or through Medicaid or a third party? And how many total number of people are getting care, right? Through visits, whether through CUC, through Integral Care, through Lone Star, through Peoples, through Ascension, through UT, et cetera, right? And maybe what is the total economic impact of our work to prevent, avoid medical expense, increase economic productivity, and save lives in the value of that work? And so I wanted to assure the board that that goal to create a central health by the numbers for the whole system is absolutely in view. It is also complicated to fully get there, and we're going to take this in some responsible steps. You're already seeing language, and actually even one slide that we did present to the Commissioners Court our last update, in which we put CUC and Central Health's budget side by side. That's where the 1.1 billion comes from. Sendero's on a calendar year, we're on a fiscal year. So there are steps we are taking to get toward that, but that is the goal, and the public deserves that. And so we are working toward the ability to represent the entire system's work in a consolidated fashion. So thank you for looking that up.
Thank you so much. So, really quick, because
as we're looking to move somewhat in that direction of what Manager Valdez suggested, let me just caution us that we can't compare apples and oranges, right? The line items are going to look different. The line items may not necessarily, cross over. So that's the only caveat. But I'm of the opinion too. I'd like to be able to see on a one pager if possible, like on a one pager where you can see where the all of Central Health and where our expenditures are the percentages of what's going to direct care or to actual health care. And then, of course, one for CUC. Obviously, we would do one similar for Sendero. But again, just the caveat is, remember, all three of them are entirely different.
Okay, thank you. I know that Dr. Yagoda has to leave in a couple minutes. So, Manager Jones, do you have a question to him or?
Well, I concur with my colleagues here is that, but it needs to be explained because the public doesn't, they have created this system and they need to understand how we're spending the money. And this year, particularly because of the uniquenesses that we're going to be going through, we need to be able to present that not only to the elected officials, but to the communities in which we serve. So that's
Absolutely,
my
yes,
point.
to the lay audience to understand. I know this is a lot and appreciate you all. Thank you, Dr. Yagoda. Thank you, Joy. Appreciate it. And we'll see you soon. And thanks for all your hard work. And next time, if you can also give us update to the legislative item related to undocumented residents, it would be appreciated.
Absolutely. Yes.
You are? Okay. I know because Dr. Yagoda was leading that effort.
We have been in very close collaboration. I
Okay,
think
perfect.
Dr. Lee will be able to carry our message.
Thank you for that. Appreciate it. Have a great evening. So we will now be presenting Central Health's budget, and the reason I know Dr. Lee had his opening remarks because because this is a whole system, and that's why we're presenting it together. But I know they'll need additional clarity of how we're presenting this information to the public and to us as well as board members. Chair Kitchen?
Yes, I just wanted to add, and Chair Musada, if you can correct me if I'm wrong, just for the board members here, our task today, and when we get to the board, and you'll get to that, is to take the next step towards, our budget adoption is on September 10th, and our public hearing around the budget is September 3rd. But what we have to do today is we have to take our vote related to the tax rate. So just trying to focus everyone on, we need more conversation about the budget, but our task today will be voting on the tax rate. So I just wanted to, thank you, Chair Musada, I just wanted to kind of focus
Thank you
people.
for that. Okay.
Yeah.
Thank you. Jeff and John, welcome.
Thank you for having us. Thank you for the conversation. Next slide, please. So we are presenting the FY26 proposed budget, and Chair Kitchen laid out the agenda perfectly. We are having, you just received the FY26 budget presentation from Community Care. We're fixing to have a continued conversation around the Central Health FY26 budget. And then just to reiterate what Chair Kitchen mentioned, at the Board of Manager meeting, there is action requested, and the action requested is setting the proposed tax rate for our public notice, and then setting our public hearing, including the time and place. And so I just want to pause for a second and just state, we're only setting our proposed tax rate for the public notice. This in no way obligates the board at this point that you're approving a specific tax rate. Next slide, please. And so, as Dr. Lee mentioned, we are looking at...
Pardon me, I don't seem to have that as part of my package.
It's a separate packet. Here, Manager John.
Okay, I'm sure, this one, right? Got it, you've got it.
It's under your sheet, your time.
Oh,
Sorry, thank you.
oh, okay.
Sorry.
Oh, that's okay. Let's get on the same slide here. So, so this is a proposed FY '26 budget of both central health and community care combined. As Dr. Lee alluded to, the public health center budget. And so there are two columns, and I won't spend much time. We have a lot more detail to go through. But this is what it looks like. Total expenses for both combined budgets, $1.1 billion. So large growing healthcare system. Next slide, please. So how did we get here today? In the budget process, I just want to go back and commend Ted and his group on really leading our community support efforts. And here's a listing of all of the community support efforts that initiated from the Dream Team. Community conversations, there were a number of community conversations, over 1,000 people in person and online. Leadership connections, Dr. Lee led some CEO roundtables with our other CEOs. Lots of connections to elected officials, community presentations and events, our health champions, training up to nearly 220 members in the community that advocate for health, and then just our digital engagement related around connectivity to thousands of social media contacts. Next slide, please. So we're now focusing more specifically on the central health proposed 26 budget. So there are 3 columns. Our goal on this slide is to show you what we presented at our last presentation for our proposed budget, what we're proposing tonight, and what those differences are. And so we're at that point in the budget where there's still some moving pieces, lots of truing up, adjusting, moving around. So just kind of starting from the column on the right, just looking at proposed FTEs, we had an addition of about 8 FTEs. You heard tonight from some of the consolidations, some of the efforts that we're making with community care to transition two things to one thing. Most of that is a transition to our facility team in Central Health proper. Let's just have one facility team and manage that accordingly. Getting to the numbers, property taxes increased slightly. This is simply an adjustment from the pre-certified tax roll to the tax roll. This is a process the tax assessor goes through every year, and we did not have that prior to our presentation. We now have that and have adjusted accordingly. I'm going to skip healthcare delivery. We have more detail on that, but that's a difference of about $12.6 million, and then just some adjustments in our administrative program, which reduces it by about $800,000. Next slide. So, as I mentioned in the agenda, one of the requested action that we'll have at the Board of Managers meeting is setting the tax rate for the public notice for our public hearing. And so this simply is the tax rate, 11.8023 cents per $100 valuation. It's an 8% over the no new revenue rate. Impact to the average homestead property is $64 from the prior year. And again, we'll reiterate this in the board meeting, but we're setting the public hearing on September 3rd at 6 p.m. here at Cesar Chavez. Next slide. So one of the things that we want to accomplish is answering some of the questions that we had. So thank you for your patience as we work through those questions. One of the questions we had, or a couple of the questions, were related around capital projects. So this slide has two elements of it. The first element of it is just on our major capital projects. What's the budget? So I'm working from left to right. So what is our budget? How much have we spent on the project today, and how much do we have left? And so that's what you see in the first three columns. You see our major capital projects: Hancock, Cameron, Colony Park, and the CEC. And you see how much is available through July 2025. And then the last column on the right in the kind of blue shading is for fiscal year 2026, what do we expect to receive through sources in our capital budget, and what do we, where are we going to budget that from a spending perspective? And so total sources are almost 25 million, and it consists of three things. One is sale of property, and this property is the sale of the community care walk-in clinic on the Hancock campus. They're at 41st and 35, I believe. So it's that clinic is part of the IH-35 renovation and has been condemned by the state, and the state is purchasing it from Central Health. Secondly is interest income. So this is just interest income that's earned. And then the last source is, last year we started a 2-year capital program. We started a $65 million funding plan. Last year we funded $50 million. This is the last piece of that funding plan, which is $15 million. And then on the expenditure side, on the budget, the $5.7 million, that's a Hancock property sale. That clinic's being relocated into the Hancock facility. So that's a funding source for the Hancock Center. I'm going to skip Colony Park for a second. We have a couple of joint tech projects. We have a communications system that we have outgrown and need to upgrade our system before we get to a point where we are incapacitated based on our call volumes. So we have a $2 million amount to upgrade that system. We also have almost $1 million, $950,000 for a project to upgrade our firewalls and cybersecurity processes. And then we have $1.2 million related to vehicle purchases in our capital budget. And then the remaining amount of that is funding related to Colony Park in the amount of $14.6 million. So that's kind of a sources and uses, kind of a about structurally balanced budget in our capital program. Next slide, please. So there's been some discussion on this. I won't spend a lot of time on this slide, but as it relates to the 2026 Affordable Care Act update, we know that there are some significant changes that are going to occur in 2026 unless something different happens through the court system. But we've talked some about the expiration of the enhanced premium tax credits. removal of tax liability caps, and then legal permanent residents will no longer be eligible to be in the Affordable Care Act. And so we are looking to transition those members from Sendero into the MAP program, and so we'll be working on that. The impact of that probably won't surprise you a whole lot. Higher premiums, there have been a number of articles around how much ACA premiums will increase. A lot of the periodicals are saying at least 20%. Fairly dramatic impact to that, reduced enrollment. I don't think that's going to be a surprise. Healthier members may elect to bypass coverage, and then just through higher premiums and affordability issue. As the ACA shrinks overall, the expectation would be there's a reduction in the overall risk pool. And when I say overall reduction, what I really mean is overall dollar volume reduction. So, sorry, I can't remember the exact number. It's a couple $1 billion, I think, that's in the Texas risk pool. The last couple of years, I would expect that to decrease significantly in 2026. And then also just, again, the increased risk of the ACA member around federal income tax liability. And really what this entails is a member in the ACA that's receiving tax credits will have to be extremely mindful of their income levels in the event that they have a increase in their income from what they were receiving their tax credits. They will be liable for those tax credits. In the past, there was a $375 cap. Moving forward in 2026, there is not a cap. Next slide, please. And so one of the questions and the proposals that we received were on the HAM partnership. There was some proposals around increasing some of the staffing, and we've been working in tandem with HAM for it seems like at least a month or so, just trying to understand what they would propose, what's something that we can work together, listening to what some of their solutions are related to some of the changes in the 2026 plan, and will more than fund the current membership level. And I'll also add that in this current year, there were no members that were trying to get into Sendero that didn't have funding. So we felt like there was a no wait line to get into Sendero. And outreach and education funding to help, manage some of the outreach that it's going to take for their membership, and to help, you've heard some about the condensed and the compressed enrollment periods, to help enroll and educate membership. And then also on the dental side of it, investing $500,000 in the HAM dental network. John can talk more about that. Discontinuance of the MAP Silver plan funding, I think that was things have really changed over the past year moving into 2026. That program is going to be extremely difficult, if not impossible, to manage. And then increase in the high-risk program funding, and with a eye towards increasing membership slightly. And I think we'll get a lot more information on that in our next item with Sendero. So I will leave it at that point. Next slide, I'll turn it over to John.
Thank you, Jeff, and good evening, managers. Thank you for your time. Another question that we were asked to expand on was the specialty behavioral health and mental health services, psychiatry services, and the agreement. Some of the detail of and complexity of our network of contracted providers gets buried in the larger budget views. So we're happy to provide this additional information. And I'll speak to each of these lines very briefly. So the psychiatric and behavioral health services are primarily outpatient services. The majority of this budget goes to integral care, but there are also services related to community care, to the SIMS Foundation, the African American Youth Harvest Foundation Trauma Recovery Center, Austin Child Guidance Center, UT Psychiatry, as well as some of the additional initiatives that we've discussed around services currently funded by the City of Austin that we're looking at potentially transitioning over the course of this year, and that includes some additional services that the city was funding at Integral Care as well. As we've discussed previously, Integral Care has experienced a pretty significant drop in their other funding sources. They've had about $17 million of funding gaps that have come up over the past year, and we are trying to help fill that void and help maintain services for our shared patient population. The three in particular that I think we're solving for in this year's budget and that have been added since our last public presentation of the budget include a $3 million reduction in their uncompensated care pool funds. Those are really general use funds that they're able to apply in many areas to help fill the gaps. So that's a federal source that has been cut. There are also fewer individuals in Medicaid due to some of the rule changes in Texas, so a state funding cut. And when there are fewer people in Medicaid, there are more people that are in MAP Basic, and are uninsured and fall to Central Health. So there's about another $3 million associated with having fewer people in Medicaid and more people being served through our agreement. There's also on the second line, inpatient psychiatric care includes both the network of psychiatric hospitals that Integral Care manages as the mental health authority, and that they do on behalf of Central Health for our MAP patient population. We have added $3 million here as well to help support services in the Hermann Center, which has lost its primary funding source through the St. David's Foundation that has funded that program for years in its startup phase, and its last year of funding happens to be this year. So we do not want to see the extended observation unit at the Hermann Center go away. It's a critical piece of infrastructure for crisis mental health management in the community, and it could be at risk of closing without our support in that area. The third area here, diversion and psychiatric emergency services. We had a 2-year ramp up of support for psychiatric emergency services. This is part of the overall diversion strategy. If you recall, we in the past year helped support the expansion of that program to include 24/7 operations, having prescribers on site at all times, and introducing 23-hour observation capabilities at that site. So again, another critical piece of infrastructure that we want to continue to support. Substance use treatment is a growing area for us, and one that we continue to propose investments in. This again includes Integral Care, community medical services, Oshkosh and Associates, the Sobering Center, including the expansion of the Sobering Center services that we've discussed in previous meetings, so that instead of holding over approximately 2 or 3 individuals to connect those individuals to treatment, this would give us capacity of between 11 and 14 individuals on the second floor. That Travis County invested about $1 million of ARPA funds to renovate for this purpose. And then the last line item here is we do have opioid settlement funds that help offset the cost of eligible expenses, so we're fortunate to have that source, but it is not clear
what the amount is that we'll ultimately receive through that funding source or the frequency of the payments that we're going to receive. While we appreciate having them, we try not to plan based on the availability of those funds. Next slide. This slide summarizes some of the changes that Jeff also discussed, but really gives you a comparison of what was in our initial proposed budget in the first column to the right of the description, what is in the current proposed budget, the amount that is different between today's presentation and our last presentation, and then again trying to provide the board with some insight into the impact on the 5-year reserve estimates for the organization. Jeff already spoke to the difference in the property tax revenue based on the certified values. There are some additional items that I'll just speak to briefly as a reminder to the board and members of the public that may be listening to this so that they can understand what has changed between this meeting and the last. Again, in the primary care space, there's a set of contracts that have typically been held by the City of Austin, supporting integral care, supporting a few of the permanent supportive housing facilities with higher complexity individuals that we think we can potentially transition those over the course of this year and help support a higher level of medical and mental health services through our permanent supportive housing healthcare collaborative with integral care and community care, providing those services on site as well. The additional team at Black Men's Health Clinic that I think was mentioned in the earlier presentation, I don't believe was in the community care proposed budget as it was prepared, but it is included here. That includes a full-time nurse practitioner, 2 medical assistants, and a partial registered nurse. And that will be available for us to work with community care and Black Men's Health Clinic to incrementally expand access over the course of this year in that environment. Right now, Dr. Jenkins runs extended hours 4 days a week, so we have some opportunity to really expand our presence in that environment while maintaining some extended hours. There are some space constraints, but there's plenty of room for us to do good work there. There's also funding here in order to facilitate some support for Austin Public Health as it relates to our patient population to help with additional screening, additional education, and connections to treatment. We've got more work to do there in conversation with leadership at APH and with community care, but we really want to make sure that as APH is experiencing funding cuts, we continue to step up and help meet the needs for our patients. We've been able to do that over the past year or two with monkeypox, with several other public health crises that have come up, measles more recently, where community care has stood up evening and weekend dedicated access for people to come in and get vaccines. We've been able to add measles to our HEB contract so our patients can walk in the door at HEB. Those kinds of solutions that help us fill the gaps that are coming on the public health side as well. The next line item, specialty care, including specialty dental, the $600,000 is a placeholder budget for us as we continue joint planning with Integral Care and with Austin Travis County EMS as we look at how we respond to mental health crisis in the community. Those two organizations collaborate to provide crisis response. I think there are investments needed on both sides of that fence, but we really want to do that in a coordinated fashion. So we've got more conversations to have over the next few months with Integral Care and EMS, but this is a placeholder that would help us support additional mental health responder paramedics. Essentially $600,000 gets you 3 additional paramedics, so that's an additional person on the ground 7 days a week, and of course the 3 vehicles that come with that, in addition to the investments we're making with Integral Care. $900,000 on post-acute care is a expansion of our respite continuum of solutions. We want to make sure that that individuals aren't leaving our respite facility at the CEC and discharging to the street unless that's their choice. We want to make sure that we have a variety of options so that we can help individuals transition and hopefully connect more and more folks to permanent housing. This also includes an amount that would allow us to reimburse the city of Austin for 20 medical respite beds that we are using today at the Arch. Those are dedicated, an expansion of what we have available at the CEC. The ACA premium assistance, the $1.2 million, Jeff talked about the HAM initiative. I would just expand a little bit on the dental portion of the program that Jeff mentioned. I think the original request from HAM was actually lower than the $500,000, but as we learned more and worked with HAM, we learned that they were having to shut down their dental program part of the way through the year. And so we want to help them right-size that and make sure that our patients that we're moving out of MAP and MAP Basic that have, robust dental benefits, that they're not getting a lesser benefit because they're in the ACA product. So that helps us right-size that budget in partnership with HAM. Outreach and education, we had additional board requests around outreach and education. This was specific to the Urban League, and I'm drawing a blank on the second. Yeah, it was APH. Yeah, APH and the Urban League. This gives us an opportunity to expand our outreach and partnership with those organizations and settings where we're serving the same clients. So these are dollars that are going to be available to help us with additional outreach and connecting folks into eligibility and connecting folks into care. I'm sorry, sir? And MAP enrollment as well. Yes, sir. This also, we had accounted for previously outreach efforts in the healthcare delivery budget. So there's a shift of some of those service agreements into the same budget area that accounts for part of the difference here as well. And then a few other adjustments, just as our finance team has been reviewing and fine-tuning the budget. Some of the positions that Jeff mentioned shifting from community care. I will call out that there is one additional FTE that we've added in the central health budget to respond to a request from the Travis County Sheriff's Office to provide some additional on-site support related to more complex individuals that we can hopefully work towards a solution where we're working side by side there in the county jail with some of our providers providing some additional assistance. Next slide.
Okay, so we have only a few more slides. So I want to talk a little bit about our reserve slide. So based on the chart that John just went through, we did look at changes. We ascertained an estimate of the 5-year impact, and so we've run that through our forecast model. And so again, there are two scenarios that we've been working off of. One is the just an 8% no new revenue rate without a debt issuance and with a debt issuance. And so the dotted line that you see on each of those are the presentation from last presentation where we're at on days of reserve on hand, and then the solid lines are the same scenario, but where we're currently at based on the revisions that we just went through. So overall, there's about a $50 million impact over the 5-year period, and you see the corresponding reduction of days of reserve for both of those scenarios. Next slide, please. And as I mentioned, we are requesting action at the board meeting for our proposed public hearing and our proposed tax rate. But we have other meetings upcoming, including our actual public hearing, which is scheduled on September 3rd, and then on September 10th, we'll be back to request approval of both the tax rate and the central health budget. And then we're scheduled on the 16th to go before the Travis County Commissioners to request approval also.
Well,
So that concludes our presentation. Thank
Thank
you
you.
for allowing us to walk through that.
thank you, appreciate it. So, members, let's first start with discussing, page 6, the proposed, so the questions are just gonna be right now related to the 8%, and then we can open it to other conversations. So, I have a question beforehand. So right now, with this 8% over new revenue rate, the, impact on residents will be additional $64, correct?
Yes, on the average homestead.
So
yes.
has there been a city and county analysis of all the impact, the new, impact on on the tax
There-
rates
there-
for residents?
There is, and
Yeah, for everyone, all the tax-paying entities.
yeah, there's a slide in the deck,
So
in the appendix.
what is that number?
Well, I think we're gonna pull the slide out and show you what all the different rates are and the impact. Oh, I'm sorry, is it in the, oh.
That was
yes.
in the supplement.
Yes, I'm sorry, yeah, let's pull that.
Page 22. Yeah, but it doesn't have that.
No,
No.
it's, there you go, slide 24, might be a little off on mine.
I don't have one.
But it's this slide right here, so this is the, yeah, thank you. So this is the, proposed tax
But
rate.
how much would it be? On average?
So I think the intent is to show, so first of all, don't get confused. It says CY, but that stands for tax year, and it's always a year behind. So what we've done here is we've taken the, can I call it fiscal year 2025 rates, and then we've taken the proposed rates of all the different entities. And so the estimate on we picked a homestead that was $515,000, so that's the average homestead. We calculated the taxes in 2025, and then the proposed taxes in 2026. So, and again, these are proposed rates based on, I know there are a couple of jurisdictions that are, that have approved elections, and so we have included that proposed rate that they're going forward with. So, what does all this mean? It means for an average homestead, again, at $515,000, the tax bill in the current year, in 2025, is a little over $9,500, and in 2026 it would be just over 11,000, so $11,084.
Okay.
Chair, I'm sorry.
Sorry, I can't see you. Yes?
This
Chair?
is Ann. May I ask a follow-up, or are you still, when you finish?
Yeah, just once Jeff wraps up, just want to make sure that.
I think that was it.
Oh, that's it, okay. So, yes, go ahead, Chair Kitchen.
Okay, so does this slide take into account the the homestead and senior exemptions?
Homestead, it does. Senior discounts, it does not.
Okay, and does it take into account the TRE that's been proposed by the city?
Yes, it does. And I believe the county also.
So in other words, if the city TRE passes, that's what we're talking about in terms of what the city taxes will be,
That's
right?
cor-
Did I?
That's correct, on a
Okay.
homestead that's valued at this amount.
Okay, with the homestead exemption, but without a senior
Yes,
exemption, right?
that's
Okay,
correct.
thank you. Thank you. That was my question. Thank you, Chair.
Thank you. I believe, okay, so, is Manager, Rodriguez online? No, so if he comes up, if he has any questions, so I'm gonna go with Manager May and then we'll go around the room. So please, managers, let's just focus on the tax rate and then we can address any other comments related to the budget. So Manager May.
This will just be for clarification. So the CY 2025 property taxes for '24, those are the ones that we paid in '25. And then, of course, the next column are the ones that we would be paying in '26.
That's correct.
Okay, thank you.
Thank you. Manager Jones?
So, this is the city of Austin. How about those municipalities that are not? Not city of Austin.
This is just a taxpayer proper in the major taxing jurisdictions.
Okay, so
So
if
there
you're-
might be some other, like, ESDs, other taxing school districts. We didn't include that, we just kind of took.
I was
the
thinking
major-
about other cities like Manor or
Yeah, we just looked at
Pflugerville or
the
those.
city of Austin.
Okay.
Any further questions? Manager Motwani? No? Dr. Brinson? You're speaking.
So, let me make sure I have the bottom line here. So, the average tax rate, if we take all into account, is going to go up $1,500 for someone who lives in an average home, $515,000 home.
Through all the taxing jurisdictions, can I say major taxing jurisdictions?
And that will be in 1 year,
That's correct.
next year.
Dr. Martin? You're speaking. You can put that.
I really have no comment, thank you.
Manager Valdez?
Thank you for this. It's, I'm ready for us to vote, but I also want us to understand that we're talking about such vulnerable people right now that are losing all the benefits that they were entitled to under ACA and healthcare. You know, all those services are going to go away. You know, the tax credits, increased premiums, blah, 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 and they're going to get hit with this. So I just want to make sure that's the correct picture for what's happening, correct?
It's the correct picture, and I just want to point out that two of the taxing jurisdictions are having tax rate elections, so it's.
I understand.
Again, we're just, we're showing the proposed rate.
Thank you.
Yes.
Well, I don't know what to say. It just puts us in a very difficult situation. I'm not a big fan of raising taxes and adding additional burden on our community members, but also we know with the current climate and the services and the needs, that is really the pressing issue. I'll get to her 1 second. So, yeah, there's a lot to unfold here. So, Chair Kitchen, you have a question? I can't hear you.
I just wanted to make a comment, but only when it's my turn. Is it my turn now?
Yes, go ahead.
Okay. Well, I wanted to make a comment on the tax rate increase. I think that, I share people's concern, particularly when I see the total level across the community that we're looking at. I do think, though, that the $64 that's attributable to Central Health is something that the reason for that is so that those folks, the most vulnerable in our community that are getting cut in other places, so that we are then turning around and making sure they don't get cut. You know, I don't know that, I hope that's what, that's certainly what my intention is to try to do. I certainly can't say that that's a 1-for-1 kind of thing, but I'm hoping that I think our goal here is by our goal about raising our $64 a year is so that we can provide the services that people are getting cut from at a federal and state level. So I feel like we have to do this to help take care of people.
Definitely, I think we all echo this sentiment, but it's just also being mindful of everyone who's going to be impacted, who barely can make means ends. So right now, I just want to make sure, do we have any,
have
Dr.
one more
Martin?
comment. Yeah, I mean, I'd like to point out something, because like you, Manager Kitchen, I agree that I think we're being tight financially, but if you look at, I mean, the majority of as a percentage, our percentage raise is like small compared to the city, which, jumped up
Yeah.
almost $1,000, and we have no control over that. I think, I agree with everyone that it's 15% tax raise for most people. But I think our part of it, I think we're being fiscally responsible, and I would support this.
Thank you. So are there any further questions related to the tax rate? Yes,
Just one
Manager
com-
Valdez.
Mine's just a comment.
Yes.
I take that, I understand, and I agree fully with what Chair Kitchen has commented on and Dr. Martin, but I just want to make sure that this board understands that when we vote for our tax rate, we also turn around and consider the changes that need to be made for who we're funding and why, because they are cut and they don't have access to those services right now, but we want to expand services to them. And we will do that. That's why we're voting for the tax rate.
Thank you for that again. Thank you.
Just one
Yes,
question. So this is
Manager
based
Jones.
upon an average of $515,000 home?
Correct. But if you had a home,
And when we, right, but I guess my question is that this is for the county-wide.
correct.
For the people we're serving, most of them don't have a $515,000 home value. So I guess my question is whether or not, I'm not opposed to this, I'm just saying, is this a way of saying, you make the money, you have to share it by taking care of others?
Absolutely.
So, I mean, I have no problems with that, I just want to make sure that that's the understanding that we're all having here.
Yeah.
My home is not 515,000, I'll assure you of that.
Okay. Okay, well, thank you all for this. So now I have a question. No, we're gonna take it at the next meeting. I have a question to you, Jeff, and this relates to Manager Motwani's board recommendation for 2020 fiscal year 2025, I believe it was. The feasibility, was it during that time period? So what's the update on that? And we had several people speak on behalf of that study. And you have requested it, and it was in the budget, I believe, for 2025. Isn't that correct?
It wasn't in the budget, it was a TBD. I met with staff about it. I wasn't necessarily satisfied with the outcome of the meeting, but staff did take the time to meet with me and share their thoughts.
But can you update us? You know, this is something that a board member had requested last year, and it's just a feasibility study that they're asking at this moment. And I understand we're also gonna have another deeper dive conversation about this as the board is whatever services we're gonna be presenting. Not for this budget year.
Yes.
I think we're gonna bring this item back, I believe, next quarter, the first quarter of next fiscal year, I believe, when we had that conversation, Jeff, that we're gonna have a larger conversation on what we fund and what our direction of Central Health. But right now, this pertains to an item that a board member had requested last year, and it was not granted. Here we are. We heard from several community members. So if you can address that, please.
Yeah, yes. So on the feasibility study, we did not perform the feasibility study. We focused on our MAP Silver plan. We ran out of time related to actual enrollment. So I think the short answer to it is we didn't conduct or complete a feasibility study related to another pilot. I think there's been some interaction with a few associations, but not a formal feasibility study.
Okay, and is this something possible that we can grant that and complete this upcoming fiscal year?
Well, are you asking, can we conduct a feasibility study?
Yes, based on the request.
We'll have a very short period of time if we're doing a feasibility study. if there's a pilot that the board is requesting, that might be a different aspect. I don't know how we would do that. There's a lot of member risk that would have to be thought through. And I guess I would just look at it as we want to make sure that any member coming into the ACA understands what the risks are related to that, what insurance is. And I'll say I'll speak for myself, I was thoroughly impressed with all of the processes and thoughtfulness that HAM goes through for their membership, including the ability to raise philanthropy and other sources to be able to help members that achieve surprise costs as it relates to insurance product, and how they help alleviate that financial pressure on their membership. And secondly, how they've already thought through the tax liability side of it, and they're already thinking about the funding philanthropy side of how they can incorporate that aspect of the ACA also, again, so that their membership doesn't have any financial surprises kind of outside what Central Health provides.
Well, HAM has been doing this for several years. They really have learned the ins and outs, so I commend them on their efforts and their work. I think primarily this is a pilot initiative that we're asking for. Manager Motwani, if you want to speak on behalf of that item.
Thanks. And, I want to say that despite the fact that I was dissatisfied with the meeting, I'm still always appreciative of staff's work, and rarely am I unimpressed with the assertions, the assumptions, and the thoughtfulness, with which y'all approach the work, our shared work. And with that said, I too am also impressed with the processes that I think HAM has helped codify and identify, as well as how they've been able to leverage philanthropy to be able to braid and also leverage as a force multiplier, right? Particularly when it comes to mitigating risk. On the sort of the scope of different funding areas, but also, like you, I think, astutely stated, around being ahead of the tax liability side of things and the risks that y'all identified, all of which to me are evidence that this is doable. And when this was presented, in fact, it was presented as a notion that perhaps could be incubated, and we could take it was literally presented, that in a manner that we could potentially take the learnings from HAM, possibly even work with them for TA in something like this. And again, when I invoke, my time in the arena in the nonprofit health and human services field, it's because I've spent many years doing case management, and understand the idiosyncrasies and the challenges of following up with clients and having the systems and the processes to be able to do so, especially through the lens of patient, client, family care, and compliance. All of that said, what I think I was most disappointed in was that I wasn't asked what I was looking for, or what I was suggesting a year and a half or two later, but I was asked why. And I feel like, I was met with resistance around risk, which is, of course, very important because it is all of our job to steward risk and protect our patients and stakeholders from risk. And that said, these were risks that we had identified and that we're well aware of, and that there is there's a roadmap on how to mitigate. So that said, I wasn't necessarily satisfied with the outcome when it comes to what a pilot looks like and what this feasibility study looks like. If I were to be asked, what do you want it to look like, I would be happy to share that. I could come up with, a pro forma pretty quickly. What I don't want to do is start to appear that I'm visioning it too much, right? When it's suggested as a feasibility study and potential pilot, which actually the potential for the pilot, Jeff, was something you had shared with me when I presented a much more lofty vision back then. is something that I think should be co-created and co-visualized. And that said, I think there were some great ideas from what we heard today. I think it can be operationalized, and I think as we move into a world with unknowns, it is more important than ever that we explore something like this in an incubated sense, in a way that we have the risk sort of encapsulated in an explosion chamber, so we know what our exposure is. When, with numbers being limited, and there are manifold reasons for this. The first of which is that we can identify any unintended consequences or notions that might pop up along the way. The second is that we could identify who could potentially shepherd an effort like this. The third is that we're hearing that 65,000 to 100,000 folks are in this population group. The fourth is that it allows us to hedge in a way that we don't know how things are going to go next year. We know that things look grim now. If things get better, if the year after, if there's been a change in political or policy climate, and if the insurance market is a safer place for Americans to look for their healthcare coverage, it would be good that we have these wheels turning now, because there's going to need to be a lot of cleanup somewhere in the future. So this would be good for us to be having models to see, wow, we've seeded this notion, invested a small amount to seed that relatively, and potentially presented a model for other philanthropy to participate in. I've heard so many cases now where we hear of X funder pulling out suddenly and we're coming in. St. David, like particularly with Integral Care, you'd mentioned a precipitous pullback of funding from St. David's, and we stepped in, right? It would be great for us to be seeding notions in partnership with philanthropy to say, wow, this worked. Organizations can take that and shop that to philanthropy to say, who has an appetite for helping this go to scale? Because this is in all of our shared values. Maybe we can't do it all, but I think that we can do something. Especially, I think, at the point that we're in now. I'm not looking to break our budget with this, nor am I looking to create a notion that would be sort of funded in perpetuity as a pet project of Central Health. Now, I wouldn't want to rule that out if it's largely successful and it presents, ROI for the taxpayer. But to me, a feasibility study is looking at, wow, what did this cost? What are the benefits? What's the ROI? Are folks better off? Are we identifying an area of population that is undercovered and getting them coverage in our year of access? And how does that potentially compare to the counterfactual, what's happening if they don't get coverage, and what are they, how much does it cost if they're on MAP, for example? And so we would have, we would have the data on paper for us to look at to see what our potential avenues are. I think we can do it. But I also deeply respect staff. I've worked with y'all for over 4 years, and I just don't know that I've had the ability to necessarily convey some of these finer points. Thank you, Chair, for giving me the opportunity, and I also see that Chair Kitchen.
Thank you. Chair Kitchen and then Dr. Martin.
I would support a motion, or if that's what would be helpful to staff, to add a feasibility study to our budget, to work with Manager Motwani on the scope of that study, and to put in a small dollar amount, a relatively small dollar amount, for to get some assistance, because I know our staff is stretched. So our staff may need to bring in a consultant to help with that feasibility study. If they do, I would support that. But I agree with everything that's been said. I think it's important to do the analysis. And I think we can do that at a relatively small dollar amount, and then we can assess what it shows us and think in terms of developing a pilot program based on what we find out from the feasibility study.
Thank you. Dr. Martin?
I'd like to express my fundamental opposition to parsing groups out. Why choose waiters and musicians over the guy that digs a ditch? Our fundamental care is for the poor. And I think that having occupied positions as a ditch digger and a waiter and a bartender, I speak their experience. The unifying experience was one of poverty, which unifies our patients. I was in Europe last year, and we were buying coffee, and the waitress, we were speaking English, and so the waitress and didn't know we spoke Spanish. And she commented that my brother had tipped her 20 cents on the 10 euro bill, whatever. And he said, well, the difference, of course, in the United States is if you don't tip the waiter, they don't eat. Here you get insurance, et cetera, et cetera. And I think I've been a waiter and a bartender. I've been a physician for Project Access, where I've cared for patients at work in bars and waitresses. I know owners came today who are not wealthy. Many restaurant owners are extremely wealthy. They choose to not fund insurance for their people. There are restaurants in town that they did fund insurance for people, like Black Star Co-op. And they put that in the thing, that people are being paid a living wage. And I think that I'm fundamentally opposed to us choosing people that we will support because of whatever their position may be. When I see our fundamental role as supporting the poor. And what unifies the musicians, the waiter, the ditch digger, is that they're unified by poverty. And I'm just fundamentally opposed to that. It seems to have welfare for specialized groups, which I'm fundamentally opposed to.
Thank you for that. Manager Valdez.
Very quickly, when I spoke earlier, talking about what appears to be more continually vulnerable and excluded groups of workers, I didn't mean any specific. But what I would like to know is whether or not that 150 to 200,000 uninsured in Travis County that we continually talk about and have not seen that percentage change in at least several years, that be identified. Because I think that all the people we're talking about, all of them, are included in that group. And we haven't done a thing to analyze where those people are or what they are. I mean, we can draw some assumptions based on what the Census Bureau tells us or what the community survey tells us or whatever. But to actually go in and do that deep dive, I think it's worthy to do that. So we will have the data right there for any policy change and pilot that could be forwarded and has been forwarded or funded, because we would know, yes, we're talking specifically about those people that are in the uninsured, poverty, less than 100% of FPL, or working poor. So I still think that is a very serious lack of data that we still don't have a handle on. Thank you.
Dr. Martin.
If I might, one last thing. I agree, Cynthia. I would argue a pilot project might be one of public education with our people. When Whole Foods was founded, he never gave insurance to anyone. No one had insurance that worked there. And people, I don't know if they were fully aware of that when they shopped there, that they were not paying for that. And I think the main thing our communications people, a pilot project to me to be how to educate the city council. How do we move this process that we become a fair society rather than the burden falling to us per se to sort of say, I'm going to capture this group and this group and this group, when the fairness is just not present. So.
Great point.
I don't want to turn this into debate.
Chair,
and I
Chair.
don't tend to, sorry.
Manager Motwani is talking. I'll recognize you.
Okay.
Thank you, and excuse me. Yeah, I think everything that Dr. Martin says makes sense. I also think everything that Cynthia says makes sense too, because we share values, right? And we have a shared sense of pragmatism, and I do think it's very important to be careful about drawing out certain groups. I think in this case, there were a couple of notions that made it a little bit more, that increased the appetite for such an idea, and the first of which is that it's high torque. There are a lot of folks in this group, and what if it did indeed coincide very deeply with this 100,000 number that we're talking about? What if there's something we could learn from that? And then, I don't think that this organization should undertake trying to insure 100 to 200,000 people. It's simply infeasible, period. However, to create the data set that would be required, are folks better off if we just looked at premiums for 25 individuals and were able to collect data on quality of life, outcomes, trauma, wellness, etc. That would be, I think that would be extremely salient. The second thing is that in this particular arena, there would be ability, as opposed to the ditch digger, for example, there would be an ability to engage with the group, because it seems that there are organizations that have that avenue to be able to engage with these workers en masse. And so that was the notion. It was about torque, hitting a large number, strategy, and the ability to engage with a common element of folks. But I get what you're saying, Dr. Martin, totally.
I'm going to recognize Chair Kitchen, and I'll get to you, John.
Yeah, I just feel like I feel like it's a population that is within our within our population. So I see it more as a not to belabor or repeat what others have said, but I see it as a way to reach those people that are already within our scope that we are to work with. The folks that they're in poverty. So I agree with you there, Dr. Martin. I don't see it as singling out people over some group over another group. I see it more as a strategy to reach a subset of the population that we need to be serving, and that would be eligible for our MAP if we could reach them, and also reach them through a mechanism that might that could be leverage other resources, or I think that's what you mean by torque, Manager Montwani. I mean, there's an opportunity to leverage what's already out there for a population that we need, that's already eligible for our services and is already within our range of services, in a way to reach them better. There are other programs out there right now, like Tex Health Central Texas, that is focused on small businesses. Many of their participants are this segment of the economy, but they haven't been able to reach all of them because they can only work with groups as a whole, and they only work with groups where the employer is willing to pay something. So they're helping part of the population, but not all the population. So anyway, I'm just saying that I think it's worth investigating.
So let's have this. John, do you have any input?
If that's okay.
Yes, go ahead.
I'd just like to acknowledge, we probably did not handle your request as well as we should have. So I just want to acknowledge that. We get.
Thanks for that. Y'all are so busy, though. I get it. Thanks.
I just we don't always get it right. So just want to acknowledge that. I think we recommended not moving forward with the pilot for a variety of reasons that we've talked about. But again, with the direction of the board, we'd be happy to re-engage in that conversation. I think to Manager Kitchen's point, there are multiple approaches and tools that we can look at to get to the same end, and I think we can have that robust conversation and figure out what makes sense.
Thank you, John, for that. I think you heard us. Maybe we'll take this offline between you and Manager Montwani. I think we need the data, and definitely, I know we want to look at poverty as a whole, absolutely, because that's within our responsibility and fiduciary responsibility to be, but also I want to honor anyone who comes and speak before us, and if there was a board recommendation to really consider that. So we'll just allow you and Manager Montwani to discuss it further, the details, and maybe you can come back and share whatever y'all have thought through. So I don't like making motions on the floor, so let's just think about it, but you heard us clearly. Manager May?
This is just a point of clarification for the discussion. Earlier, we heard from the folks in the public that came to testify. Then we said that for us to hold off all our questions till we got to what I thought was going to be closed session.
No, it's open.
Oh, this is the session now.
This is it. So this is the opportunity for you to discuss.
Okay, well, then I'll go ahead and speak my piece.
Yes, go ahead.
Sorry. Okay, so first of all, let me just say that I have really enjoyed the conversation. in the dialogue between all of us, because I've actually learned a whole lot. So be that as it may. I believe in principle with what Dr. Martin is talking about, because yeah, the problem is poverty, right? I mean, that is the problem. So I have tremendous respect for that, the way he phrased the issue at hand for us. Now, as I see it right now, this is why what I was going to say earlier before all this discussion came forward. You know, we're raising taxes on our public. Whether it's $64 increase from last year to this year, regardless, that's a tax that's going to be increased, and it's our tax. And then further, we have other entities that we already know about are going to be raising taxes as well. Whether this population that came forward asking for help, asking, there were two, as I saw it, there were basically two groups that were asking for help. You had the integral care workers that would like to see a better raise than the 4% that they got, or that was being proposed. So that's one issue. And Ann's going to speak to that, she said, or she sort of kind of spoke to that. I would be very interested in having a report back from Integral Care about what they decided to do on that, because again, we're raising our budget to accommodate them, and I'd like to see them also take care of their employees. That's one way to look at it. I'll have all the details of what's going on with Integral Care's budget, but let's put that out. I want to put that out there. Second point, with respect to the pilot project program, this is the working poor. These are people who are working for wages. It's not like they're out in a corner, and forgive me for those of us that have very strong commitments to the homeless population, because I respect that, and I also believe in that. That's why I've supported funding all these other programs. But I mean, it's very different. These people get up and go to work, they tolerate whatever they tolerate in their working conditions. And then they're not being paid what would be a living wage, a $2 an hour, whatever. Some of these people get tips. Some of these other people don't get tips. And I don't know which ones. I think we got an idea who gets the tips. But in some restaurants you go in and it's nicely, evenly divided. They share the tips evenly with everybody that's employed there, which is wonderful. But not all restaurants do that. So from my perspective, I would like to be responsive to the people that are working, the working poor, on a more immediate level. I don't know what a pilot program would look like. I don't have any idea what their thoughts were on that. I would leave it to, obviously, our staff to explore that, come back and talk to us. Does it look something similar to HAM? I don't know. But I'm interested in doing that, because I think that if we're going to raise taxes, and it's because we're trying to help we're trying to help everybody, or as many people as we can that are either uninsured or underinsured. For God's sake, we need to help the working poor too. That's just what I gotta say.
Thank you, Manager May. John, do you have something quick?
I was just going to add for the board's awareness, I failed to mention this earlier, but in the amounts that I went over in the specialty mental health budget, we have allocated dollars like we do we have dozens of healthcare partners that we work with, but we have allocated dollars in our budget to adjust rates in our contract that can hopefully help do our part to allow Integral Care to address some of the concerns from their workforce. We make similar rate adjustments in all of our agreements. We look at those every year and make sure that we're competitive, but that we're equitable, but the workforce challenges, the recruitment and retention here in Austin, the cost of living is very real and is felt by a lot of our partners, and that's something that we try to take into account as we're renewing our contracts every year.
Okay, thank you for that. And I know we'll expect also an update from Chair Kitchen after the board, Integral Care's board meeting tomorrow. So at our next meeting, she will hopefully update us.
Yeah, and I'll talk to Dr. Lee. You may want to talk to the Integral Care CEO. He may want to come and talk to y'all directly. So I'm sure that can be arranged also. So.
Okay. I am going to go, Manager Jones, do you have any questions related to the budget?
No, just on this last issue, I would encourage that we put a working committee together to come back. Sounds like that's what we're going to do with recommendations. Put a pin in it and let's move on. Because we're saying the same thing over and over again.
I agree. Thank you. Manager Motwani, do you have anything further?
Thanks for the airtime. I appreciate it.
You're welcome. Dr. Brinson?
Nothing to add.
Dr. Martin? Manager Valdez?
Just do it.
Okay, perfect. So, managers, there was not a motion for this item. I do also I had specific questions related to Dell Medical School, and I'm hoping that they get answered before our budget vote. So I'm just gonna leave it at that point, so. Yes, sorry?
Are we not get to the discussion this?
You wanna do you have anything? This is it. This is the budget. We don't have anything else. Do you? I said if you have any questions related to the budget, I'm happy to take them.
Well, this is the taxes here.
But no, we talked about, I said, we had our tax,
Yeah, but on the budget,
we had
We
our
said we
tax
would
conversation, but now you can talk about the budget.
Chair Kitchen.
Yes,
Chair Kitchen, before I respond.
yes, Chair Kitchen.
Oh, yes, just as a reminder to everyone, that we will hear more from the public on the budget on September 3rd. That's our public hearing. And then we'll vote on the 10th. So I'm not trying to suggest you don't talk about it now. I'm just telling you, I'm just reminding everybody you got 2 more occasions to talk about the budget.
I understand. I think we just also there were some concerns and questions.
Well, we spent the evening talking about some of our concerns and shortfalls here. Just imagine what we could do with $35 million in trying to fit some of the pieces that we've talked about. Now, whether you agree or disagree, I think it's a question that needs to be vetted in the public. It's not my dollars alone, it's all of our dollars. And there are members in our community who have said they have no idea of what we're doing or of what Dell Medical School is doing in their community.
So Manager Jones, not to interrupt, but I forgot to finish answering your question. There's a agenda item on the Board of Managers meeting tonight to give you all an update related to Dell Medical School. So that's the next meeting.
Well, I just thought we said we didn't have that.
Not today.
We don't have an update. You have an opportunity to ask any questions that you have or any concerns.
No, wait a minute. There is an agenda item in executive session under the Board of Managers meeting that it's an update. It's not going to provide it's not going to answer all your questions, but it will provide an update on where the staff is in their process. So that's all I want to say in open session right now.
And that's what I'd be interested in doing.
Well, I would suggest that that agenda item might be the best item to have this conversation under.
Well, it would have been great if the chair of this committee knew about that item. That would have been helpful. So, thank you. Do you have any further questions, Manager Jones? Manager Motwani, I don't see you. Dr. Brinson?
I'm sorry, I wanted to ask one question. On the vehicle cost, what are the vehicles?
Oh,
Yeah.
yeah, sure. So we are hopeful that we were able to participate in the purchase of a mobile vehicle. So we're just putting a placeholder out there in the event that we have an opportunity to embark on that.
And as a reminder, we've got 2 additional mobile teams that are part of the budget to help support individuals experiencing homelessness, some of our partner organizations, and bringing healthcare on site for them, and also serving the permanent supportive housing facilities in partnership with Community Care and Integral Care. So that's part of the discussion, but I think that was another question that we'd received from the board of can we look into opportunities to have more mobile units that are available in the community. So I think we are looking at multiple options there.
Any further questions, really quick?
Just a follow-up on that, and to know whether or not we could send not only those mobile teams into the finite sites of the homeless locations, but into poverty neighborhoods that can't get to or haven't been able to access healthcare at clinics. So.
Okay. Well, thank you. So that concludes agenda item number 4. So members, I know there's food, but I am going to take item 6 and then we'll come back to item 5. Agenda item number 6, receive and discuss an update on the Central Health business meal reimbursement policy. So members, there's no presentation on this item. There was a policy in your packet, backup, and staff are available to questions. I have a question personally related to that. So it's really vague to me, the numbers. I think the amount, like what it is, it designates certain groups to higher rates than others. They didn't have that specified, so I was wanted like more further details. It wasn't very clear on that policy, so if someone can answer that specific question. Doesn't state it, no. That's, and it doesn't really, it's, so, hi Nikki, really quick, I know we're not up for an, but if you can offer further clarifications on that policy, please. No, it's not for everyone. Yes, Nikki, welcome.
I'm sorry, what is the question? Okay. Excuse me, so this is basically the business meal reimbursement plan for executives, well, it says in the scope, Central Health executives, vice presidents, and then the associate chief medical officer. And then they're called team members throughout the policy. So it's only for those select few who meet regularly with partners, members of other organizations that we team with, where we might discuss business.
So, to me, like personally, and I think like here you have the limits. What's the limit? So I think to
Okay,
like, further
so if you go
clarifications on that.
to, so per diem, we kind of did it the same way that per diem works for travel meals. You get a certain amount for breakfast and certain amount for lunch and certain amount for dinner. And those we just increased a little bit for these non-travel business meetings. And so for breakfast, we will only reimburse or put on a P card up to $20 per person. So if you have a $100 meal, the total is $100, and you have 5 people, that's $20 a piece, so that is within the policy.
Okay.
For breakfast, correct. But that would be okay for lunch and dinner too. But you can't have you can't pay $50 per person for breakfast.
The speaker, can you do?
Because I thought I read the materials at home, but anyway, I thought I saw it was 20 for breakfast, 35 for lunch, and then 50 for dinner. Am I reading that right somewhere?
Yes, it's on the second page.
Okay, so essentially it's $100 is the limit.
No. So one meal, it can only be during breakfast or lunch or dinner.
Right, but per day, say you're at a conference, right? And you're on your own for lunch and breakfast and
This
dinner.
isn't travel meals. This is not for travel. Travel is a completely separate policy. So this is non-travel. I might be able to put that in the definition, but this is not travel meals. This is when Dr. Lee wants to meet with the dean of UT. They go out to lunch, and he pays, and if it's for breakfast, he can pay up to $40.
Okay. Any questions?
I have a question. First of all, I'd like to amend the policy, and we'll look at making recommendations, but I want to understand. We're talking about the highest level of executive at Central Health who is well compensated, according to the numbers that I've seen. And it's however many people that is. Do we know how many people that is? Who
I'm sorry.
qualifies? How many people? Is
I don't know
it
the
one
exact
person? Is it
number
5
of-
people? Is it
I
10
think
people?
Central Health executives, I think there might be 11 or 12 executives.
Okay, and we're talking about meals that they're not traveling, they're here in Austin. They get a salary, and they're talking to each other.
About business. It's only business meals.
Well,
It's
you
not
know, I can sit in my
personal
office
meals.
at in a meeting, in the conference room, and do that, and not have to put my request in for this money. I'm just looking at hypotheticals. You know, we're sitting here concerned about the value of healthcare, and the numbers could be hundreds of thousands of people that aren't getting it, and we're talking about like Integral Care or some of the others that have frontline employees that were not compensated, are not being compensated, and it's almost like a slap in the face to the worker that is not at the highest level or highest tier of administrator or executive, and they're in town, they're not in a meeting, it's not travel, and have a meeting in your offices, or everybody take turns, you know, I don't know, I'm just saying that it just doesn't, the optics do not look good for Central Health, is what I'm saying, and I think something needs to be maybe talked about, maybe not right now, but it talked about.
So again, this item is not up for vote or anything. I just wanted to bring this to your attention. If we have any questions, we'll come back to you.
Okay.
Thank you.
Thank you.
So members, we're going to break for really quick for anyone needs to grab a meal. And then we'll come back at 7:30 to take the Sendera item. Did you all hear me? So we're convening the Budget and Finance Committee meeting, and we're going to start with agenda item number 5, receive and discuss financial and operational updates from Sendero Health Plans. Sharon Elvis will be presenting. Members, we're going to take this to closed session. I announce that the committee is convening closed session to discuss agenda item 5 under Texas Government Code 551.085, Governing Board of Certain Providers of Healthcare Services, and Texas Government Code 551.071, Consultation with Attorney. So it is August 27th, 2025, and it is 7:36 p.m. Okay, so we are out of closed session. Today is still August 27, 2025, and it is 8 p.m. And we discussed item number 5 in closed session. There's no motion for that item. Now we are moving on to our final agenda item number 7. Confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, September 24, 2025 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment. Dr. Brinson moves, seconds by Manager Jones. Any discussion? All in favor?
Aye.
Meeting adjourned.
All right, so we're going to go right into the Board of Managers meeting, and I'm going to change one thing. So instead of us starting out with Dr. Lee, it has been requested that we start out with item number 2. And then after that item, we will then go back to Dr. Lee's. Oh, and yes, and Manager Jones wants to make an announcement.
Yeah, I'd just like to acknowledge something. This past Sunday, the Central Health Community Outreach Team did an excellent job going to David Chapel Missionary Baptist Church here to do a health screening. I'd like to thank Dr. Lee. I'd like to thank Ted and his team for doing a fantastic job. The church was very impressed. The community was very impressed. It's those kinds of things, particularly in the African American community, that sends the message of importance of screening. They did some screening. They did for A1C, HIV. They did some educational activity. I think they did some MAP enrollment, a variety of things that were done, and it was well represented. So I want to acknowledge you, Ted, and your team for doing a great work.
The dream team.
Thank you.
All right, so we are going to just move directly to item number 2 under the regular agenda. Discuss and take appropriate action on Central Health's proposed property tax rate for fiscal year 2026. Jeff Canodal and Nikki Riley will be presenting.
Hi, Nikki Riley, Deputy Chief Financial Officer. I do have one slide to put up, which is the tax rate slide. This is going to be the same slide that you saw during the budget presentation. So this is the fiscal year 26 proposed tax rate. It is 8% over the no new revenue rate. Maintenance and operations tax rate is 11.3569. The debt service tax rate remains pretty steady at 0.4454, making a total tax rate of 11.8023 per $100 of value. And this is with a homestead exemption of 20%. The 65 and older and disability exemptions have gone up to $185,200. For the average homestead of $515,000, it makes the tax rate, the tax dollar amount go up $64.
How much?
$64.
Any questions? No, okay, so we need a,
Can I make a motion?
yes, please.
I move that the board approve a proposed total property tax rate of 11.8023 cents per $100 of taxable property value for the 2025 tax year, which will support Central Health's fiscal year 2026 budget.
Do I have a second? Yeah. Cynthia Valadez seconded. So, we have a motion. Oh, yes,
No, I'm waiting for a discussion.
okay, oh, Okay, good, okay. Okay, well then we should have the discussion now, because
Yeah, okay.
next we're gonna vote.
Okay. I just want to make a comment, and that is that the tax rate that will be generated will be the rate that will generate for the operations of this district for the next year, if I'm correct. Recognizing that within that tax rate is $35 million that is devoted towards an institution that is supposedly providing health care to this community. I think the citizens of Travis County need to understand and hear from that institution that $35 million of this new tax rate is going for services that they may or may not be familiar with, and that they should do a better job in informing the community on a routine basis of the expectation of them for this money. It is not fair for taxpayers to be paying. They get police, they get fire, they get other services from us. But here's their $35 million, over $350 million over the last 10 years. And I hear frustration that they don't see what they get for their dollar. And so I would encourage us to do one or two things. One is to ask the dean to come back and talk about a strategy of better improving that education to the various residents of Travis County, particularly those in the Eastern Crescent. Second, if they're not willing to or not able to, then I suggest that we consult with our Travis County attorneys to see whether or not we as a board can recommend to the Commissioner's Court that that tax rate, those dollars be put on a petition, and what's the word? Voter referendum to be repealed. I think we need to put pressure on them to do something, and the only way that there seems to be responding is to put pressure on them. And if we don't put pressure, no one else will. So I just put that for discussion. I don't expect a vote on it, but I think we don't need to just drop it as an issue. That's a lot of money.
Dr. Brinson.
Well, Eliza, do you want to go first?
Certainly. I certainly concur with Manager Jones's comments. I too feel very frustrated by not having, you've got Ann. Did we want to include her first? Or keep going?
Well, Ann is included, yeah. Well, but I already asked you to start. So.
Okay, let me just
Go ahead, Elisa, go ahead. I can wait.
Sorry about that. So I want to make sure that my colleagues here understand that I concur with Manager Jones. I have been very frustrated. Personally, I've asked for information. I haven't liked the responses I've received. And so I feel like, it doesn't matter what role we play, we don't get the information we need. But be that as it may, I also believe, and I understand clearly the important role they play with Central Health and how important it is for our future to have a good relationship with them. So I want to acknowledge that as well, despite all my frustration. I will support this. The other thing I want to make clear is that I am supporting the tax increase for two reasons. Number one, it's my reaction to what's going on with all the dynamics of the federal government, the cuts, the big beautiful bill, et cetera, et cetera. And so this is my way of trying to bridge a little bit of those cuts. And if this is the way we go, this is what we have to do, this is what we do. And this is why I've supported all of the other little programs that we've added to the budget that would, we hope, would at least provide some bridge to some of the services that are being cut. I just wanted to say that. Thank you.
Thank you. And Ann, Manager Kitchen, did you want to?
Oh, I just wanted to suggest for folks, I know that there's a lot of questions folks have and maybe want to have some conversation about the 35 million. But I just wanted to suggest that there is another agenda item, and we might want to give staff a chance to share what the update they have before talking more about that particular thing. I'd like to just get to the vote if we could.
Well, if I may respond, I'm not suggesting that we don't. I want it on the record, though, that before we.
That's fine.
Before
I
we-
wasn't talking about you, Shannon. I
Right, no,
wasn't
I
trying to
understand.
suggest.
But before we vote, I want it documented for posterity, that we went on record saying that we are not supportive of giving money for a result that we don't have. Now, we can go ahead and vote to support it, and I think the discussion we'll have will maybe be helpful. But I think before we vote, it should be noted.
That's fine. Everybody is entitled to make their own comment. And as we all should, I will just say that I don't share those concerns. I think it's helpful for more information to be provided to the public, but I think that we are receiving information from Del Medical. But the overriding thing for me is that that it's important that to vote on the. I am going to support this tax rate because I think it's really important for us to serve our folks.
Okay, thank you. Would anybody else like to comment? Manager, yes.
I just want clarification, and Ann may need to chime in on this. I want to know whether or not it would be possible when we do get to actually vote on the budget, whether we can ask that the $35 million tax amount that's supposed to be paid by us to UT actually be pulled, and that be a separate vote on the budget. I didn't know if we could do that, but I have seen it in the past, and I just wanted to know whether or not we could do that again.
Yes.
I believe it is. Every year it is
No,
pulled.
it has been in the past.
Yeah.
Today, we're just
It is.
voting on the tax rate.
Correct, but once it comes
when
to
we
that
get to the
vote, it is pooled, and because there are few members who do, I don't know right now, but there are some members who have conflict of interest.
No, I know,
Either they
yes.
work or whatever, or they, duality of interest, they do not vote on that item. So it has been in the past. So if I can make a comment?
Yes.
Thank you. Today we are, oh, I'm sorry,
I just wanted to say
Yeah,
one
go
more
ahead.
thing, because we're in executive session, and
we're
I'm,
not.
well, I guess I'll just wait till we go into executive session at some point. But I am concerned, and I'm just disappointed that we did have a presentation by the University of Texas Dell Medical School dean, and that was the very day that UT terminated the existence of the health equity department and fired its staff. That morning of the day she came to present to us, and she didn't tell us that. And I think that goes in the face of our mission and our value as a health providing entity to our poverty population. And I just wanted to make sure that they understood that that was not appropriate and it was not professional.
And
thank you.
And if I may say, my position is not that I'm opposed to the rate. My position is that I want to send a message by voting on this. We are not necessarily agreeing with UT, is what I'm saying.
Yes. All right. So we have a motion by Manager Musaitov and seconded by, who seconded it? By Joe Martin, Manager Martin. So Miss Brianna Harris will now assist me in taking a roll call vote. For the roll call vote, Miss Harris will call the name of each board member in attendance in alphabetical order. Each board member must indicate whether they are voting yay or nay or abstaining from a vote on the proposed tax rate. Ms. Harris will confirm your vote before moving on to the next member to ensure we have an accurate vote tally.
Instead of going in alphabetical, I'll probably just do virtual and then left to right. Okay, so starting with Chairperson Ann Kitchen.
I vote yes.
Chairperson Ann Kitchen votes yes. Manager Cynthia Valadez.
I vote yes.
Manager Cynthia Valadez votes yes. Secretary Manuel Martin.
I vote yay.
Secretary Manuel Martin votes yay. Vice Chair Cynthia Brinson.
I vote yes.
Vice Chair Cynthia Brinson votes yes. Treasurer Maram Musaitif.
Yes.
Treasurer Maram Musaitif votes yes. Manager Amit Matwani.
Yes, thanks.
Manager Amit Matwani votes yes. Manager Shannon Jones.
I abstain.
Manager Shannon Jones abstains. And Manager Elisa May.
Yay.
Manager Elisa May votes yay.
All right, thank you all. So now we're going to go back to the beginning all right, so consent agendas. Okay, first, I move, committee agenda. Okay. Good afternoon, evening. Today is August 27th, 2025, and it is 8:15 p.m. As a quorum of the board is in attendance, I would like to call to order the meeting of the Central Health Board of Managers. As a reminder, some of our board members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. We will now proceed to public communication. I would like, no, there are none? Okay, I'll skip it. All right, we will now proceed to the consent agenda. C1, C2, and C3. C1, approve the minutes of the Board of Managers July 23rd, 2025 meeting. C2, receive a report on Central Health investments for July 2025. C3, accept an in-kind contribution from Univision and Fiesta Tortilla for the upcoming Viver Con Ganas Health Expo on September 27th, 2025, as recommended by the Budget and Finance Committee. Yes, Manager Mawani.
I move that we adopt the consent agenda.
Thank you. And Cynthia Valadez is voted second. We will now proceed. Oh, discussion? I always forget that. Discussion. Any discussion? No. Vote.
Aye.
Aye. Okay. All right. Now we will proceed to the regular agenda. So 1, receive and discuss a report from the President and CEO, including priorities and key results, the leading edge, emerging issues, what we're solving for, outside, inside, and our mission moment. And Dr. Lee will be presenting.
Okay. Good evening, board managers. I'll begin with a concise update on our strategic and budget priorities and key results, focusing on what moved the needle and what's coming next. So starting with access and capacity, specialty care is ahead of plan with 14,800 encounters year to date against a target of 13,500, driven by new launches in ear, nose, and throat and physical medicine rehab, and continued ramp up in general surgery, endocrinology, and rheumatology, and supported by tighter referral workflows with community care. Respite care at the CEC is open and serving patients, 16 patients to date with 7 bed days recorded in July, and throughput will build as operations stabilize post-launch. Moving on to care coordination and social supports, post-acute coordination has delivered 1,607 care episodes year to date, including 1,261 inpatient transitions and 346 skilled nursing episodes. A 4th skilled nursing team comes online in September and October to sustain volume and quality. The medically tailored meals initiatives moving to execution. Final vendor contract and scope are issued. An external audit vendor and schedule are embedded, and the workforce development RFP closed August 15th to support scale-up. On to enrollment and coverage. MAP and MAP basic enrollment stands at 98,750 compared to 92,000 target, with an average monthly enrollment up 12.6% over last year. 10,700 of these enrollments are among individuals experiencing homelessness, compared to 8,300 at this point last year, with some softening in new enrollments being monitored closely. Sendero's high-risk premium support program, the CHAP program, has 923 unique enrollees year to date, meeting the calendar year goal for medically complex members. In terms of system infrastructure and workforce, our data governance platform is live in both test and production with broad metadata ingested. The Governance Council launch and platform stabilization are underway, and a manual lineage workaround is in place while a vendor fix is pursued. The Medical Assistant Apprenticeship Program continues to deliver talent. 4 cohorts to date completed with graduation rates above 90%, and 21 medical assistants across our system are hired. Cohort 5 launched in July 28th with 10 candidates now in rotations with us. Our team member experience survey is configured and set for September 8th launch to drive targeted actions tied to culture and retention. In terms of strategic system work, the ambulatory access and quality plan has been drafted and is in beta testing at North Central, with 5 clinic volume dashboards live for central health and community care integration in motion. The integrated care system vision is continuing to advance through our strategy cascade. It's moving toward a synthesis retreat to finalize its future state. Service consolidation goals were met in eligibility screening, credentialing, and transportation between our 2 organizations, Central Health and Community Care, with FY26 opportunities identified in homeless services, EPIC, addiction medicine, and pharmacy. Public value signals remain strong in terms of communications, with over 184 million impressions of our materials across Travis County and Texas this year, 153,000 engagement interactions, and 97.5% of positive or neutral sentiment from the public since October 1st, all reflecting rising trust and transparency. Our near-term focus is to sustain specialty access above the plan to build out the CEC respite throughput and stand up that 4th skilled nursing team. We're also activating the Central Health Initiative Fund operations and audit readiness, launching the team member experience survey, and completing data governance stabilization to support the FY26 performance goals. On to leading edge. A brief update on how we're advancing daily management and clinical safety across our system. At our East Clinic in Rosa, Zaragoza, we have successfully launched huddle boards. The East Clinic was launched in June and Rosa Zaragoza in July, and they are already driving stronger team communication, quicker problem solving, and the ability to celebrate wins on the floor with the frontline teams. Our nurse leaders at Respite, Bridge, and Capitol Plaza multi-specialty are queued up next. So this is spreading and will become a consistent visual daily management system across our sites. This has been a highly collaborative lift between nursing, the transformation team, and performance improvement, working hand in hand with clinic practice administrators and our physician leaders. Dr. Subash in particular brings deep experience with daily management systems and will help evolve these boards to reflect clinical outcomes, creating a direct line of sight from frontline work to patient results. At our East Podiatry service, we are safely launching wound vac, negative pressure wound therapy, infection prevention supporting with targeted training that focuses on cross-contamination prevention, addressing safety and staff protection. We're preparing a concise IPC addendum with vendor education to ensure regulatory readiness and safe practice on day 1. A special thank you to the East Podiatry team for leading with a safety-first culture that improves outcomes for patients while protecting our clinical teams. Before we move forward, a quick note on emerging issues. Those items will be handled through recent closed session and offline consultations with the board, so nothing further for open session today. Turning to outside inside, an update on our community presence and our people. On the outside, we presented the FY25 Q4 update at the Travis County Commissioners Court during our August 12th work session. That briefing covered budget actuals to date, healthcare delivery updates, partnership updates, the Mazars Performance Implementation Review, FY26 budget development, and other items required by the amended financial order, our final FY25 quarterly update to the court. Also on the outside, we concluded the CEO Roundtable series with a focused discussion of FY26 budget priorities. Stakeholders emphasized the need to educate the public on upcoming ACA tax credit changes, the implications for patients, and our capacity to absorb increased demand in MAP and MAP Basic, along with questions on the anticipated tax rate increase. We hosted 18 community and partner leaders at the airport administrative offices for that dialogue. Looking ahead, Central Health will present the FY26 budget to the Commissioners Court on September 16th, requesting approval of the proposed budget and of the key milestone for access and equity in the year ahead. On the inside, our outreach and engagement team spent last Sunday with the community at David Chapel Missionary Baptist Church, as Manager Jones shared. Nearly 100 individuals engaged to receive information, complete health screenings, and learn more about the medical access program, strengthening trust and connecting residents to care pathways. We want to give a special shout out to Manager Shannon Jones for creating this viable engagement opportunity with our Black African American community. We're also launching the inaugural Team Member Experience Survey led by engagement and retention teams with strong partnership from internal communications. This baseline across our system will give us actionable insights into the team member experience, establishing a foundation to measure progress and guide strategy that strengthen culture and support high quality care. And we'll mark Austin Pride Month in collaboration with community care sexual health providers, joining them in tabling at this year's celebration. This is about equity, inclusion, and connecting LGBTQIA+ community members with essential resources and services, reflecting who we are and how we serve. On to what we're solving for. A brief look at some of the foundational work that enables scale and reliability. First, AI governance. To move quickly and safely, we've engaged a third-party partner to document current AI use cases across the enterprise. This will establish a governance framework and an enterprise policy. It will deliver a set of high-priority scenarios that improve productivity and service quality while maintaining security and compliance. Second, data alignment. We are aligning the data engineering and data analytics teams to anchor the FY26 performance portfolio. Most of our FY26 objectives and key results are data-driven, and this structure will improve prioritization, throughput, and clarity for enterprise data initiatives, and it will accelerate decision support across operations, clinical services, and finance. Third, platform migration. We continue to migrate from our legacy data warehouses into our new Snowflake data lake. The goal is straightforward: streamline access, strengthen data quality, enable faster analytics for clinical, operational, and financial use cases. This is the plumbing that will power better insights and better service at scale. And before we close, a brief mission moment. Glenda, A Life Renewed Through Care and Connection. This story highlights how coordinated services and compassionate teamwork can restore health and dignity for our neighbors who need it most. It's a reminder that every process improvement, every governance decision, and every community partnership ultimately adds up to real people and real outcomes. Thank you.
All right, so now, just to make things confusing, we're going to move to,
Team, are we going to play the mission moment just before we?
well, yeah, sorry.
Yeah, no, sorry.
Chair, or
Yes.
while they're queuing up the mission moment, just wanted to first of all acknowledge a great report. Also on the outside inside, I wanted to also acknowledge that we have Ms. Ora Houston listed here, and I know it's after the fact, but if we could list her as the Honorable Ora Houston, she's a former City Council member of District 1. Thank you.
Thank you. Will do.
And I have one question, Dr. Lee. You mentioned otolaryngology in passing. What's come of that? ENT. What's happened with ENT? You mentioned that in passing.
Yes, ENT is live in Round Rock. It's been live for.
First surgery scheduled for 3 weeks.
Good.
Yeah.
Super.
Yeah.
Thank you.
I'll add the team has so much experience now in standing up services that after preparation, they literally opened the door, and 8 hours later, they had the service stood up. So in a single day, they stood up the ENT service line. Pretty impressive.
I haven't had a phone in many years. I haven't seen a doctor in many years until last year. I didn't care if I did, and I care now. My kidneys shut down, and I needed a lot of help. I was very, very sick. I took 26 pills a day. The phone, It's like literally saving my life because it's helped me by becoming more of an adult to be able to make my own appointments, to make sure I get to my appointments, to make sure I have a ride to my appointments, to get my prescriptions, to get my support that I need from my case managers, and to help me get in touch with my case managers to get my disability, which will help me proceed in my life healthy. So, you know, that's important. Rita is my only support that I have, and she's been huge. She has made me take more responsibility. She helps me every day, literally every day. I call Rita every day or text her. She's helped me, you know, she's helped me trust people again. My goals, that's a scary word for me because I haven't had to have goals in over 20 years. My goals, you know, I want to be able to maintain at least where I'm at and not slide back. I want to be able to stay in my own house and make sure that I stay seeing my doctors and my medications, because if I don't, I will die. We're in my apartment. It's kind of scary because I haven't had to be a responsible adult in a really long time. So it's kind of emotional for me. But it's going really good. I've lived here almost a month. And I've got a case manager here that helps me. I've still got Rita. So it's a kind of a new gateway for hopefully my family to come back in my life.
You don't need Facebook or ClickBank to succeed in affiliate marketing.
Thank you very much. That was great. And so now we're going to move to number 3 under the roll call vote. Set the date, time, and location for the public hearing at which the Central Health Board of Managers will present and receive comments from the public on the proposed fiscal year 2026 tax rate. Jeff Knodel and Nikki Riley will be presenting.
Hi. A public hearing on the proposed tax rate will be held on Wednesday, September 3rd, 2025 at 6 p.m. at the Central Health Administrative Offices at 1111 East Cesar Chavez Street, Austin, Texas, 78702.
All right, so can I get a motion? Manager Valadez?
I move that the public hearing of the proposed tax rate be held on Wednesday, September 3rd at 6 p.m. at Central Health's administrative offices located at 1111 East Cesar Chavez, Austin, 78702. A notice for which will be posted on the Central Health website and published in the American Statesman.
And do I hear a second? Second. By Manager May. And all in favor? Aye. All right. Any opposed? Any abstaining? No. So, members, before we move on from this item, I would like to emphasize to the members of the public watching that even though a quorum of the board will be meeting in person, the public can still participate virtually in the tax rate public hearing. We strongly encourage all members of the public to participate in the meetings on the virtual link that will be provided in the notice and to submit any comments through that method. All right, now I announce that the board is convening in closed session to discuss agenda items 4, 5, 6, and 7 under Texas Government Code 551.071, consultation with attorney, and agenda item number 8 under Texas Government Code 551.071, consultation with attorney, and Texas Government Code 551.074, personnel matters. Okay, let me know when we are. So, 4, receive and discuss an overview of legislative and regulatory issues impacting the Central Health System. 5, discuss updates on matters related to a performance review by Mazars USA contracted by Travis County. 6, receive and discuss a briefing regarding Travis County Healthcare District DBA Central Health versus Ascension, Texas FKA Seton Healthcare Family, cause number D1GN23000398. 7, receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District DBA Central Health and Dr. Patrick Lee, cause number D1GN17005-824 in the 345th District Court of Travis County. And number 8, deliberation and possible action on the appointment, employment, evaluation, reassignment duties, disciplines, or dismissal of one or more Central Health employee. Oh, and it is now 8:35 p.m.
Recording in progress.
All right. So it is 9:37 p.m. on August the 27th, 2025, and we are back in open session. So now we are going to confirm the next regular board meeting date, time, and location. Managers, the next Central Health Board of Managers meeting and the public hearing on the district's tax rate is tentatively scheduled for next Wednesday, September the 3rd, 2025 at 6 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. At this time, I am ready to accept a motion for adjournment. Okay. Manager Martin moves first, and Manager Valadez is the second. And all in favor? Aye. Any opposed? No. Okay. Thank you all.